families if you don't understand. And I will ask the professionals to be indulgent as well if some elements sound simplistic. We have a rock star coming from Orly right now, Professor David Geneviève. Hello, Professor. Okay, we're going to start. Your presentation lasts about 10 minutes. You have all the tools. It's called the symptoms of the genetic disease and the function of the gene. You've been able to enlarge your panel of patients thanks to the Association Extraordinaire. Huh? Let's see if your microphone is working. Well, it has. Yes, it works better that way. Yes, very briefly, in the clinical genetics departments, we managed to give a diagnosis, but it's not enough. We also need to understand the pathology. We need to understand better the life course, and then it enables to give a proper diagnosis. But to do this, we need the support of the patients, of the carers, and why not an association to get all the association together, or all the information together. So the association has supported us and helped us advance in our research. Okay, so you have about 10 minutes. We have Justine who will be taking care of your timing. Over to you, Professor. So, just one word. It seems there's a slight mismatch between the screen and what I want to tell you. Okay, so a few info. I want to give you a snapshot of DDX3X. So it's a genetic disease described for the first time in 2015, so not so long ago. And quickly we understood that it was a very frequent cause of neurodevelopment disorders in girls or women, over 150 in the literature. But if we probably looked at all the literature, we would have a much larger figure. But it was also described that same year, 2015, in boys, but it's not as frequent. So you can see family forms in boys, and a schematic representation of the DDX3X protein. Here you can see the difference between boys and girls.
Neurodéveloppement avec probablement une atteinte cognitive plus sévère chez les garçons.
So there must be a more important cognitive approach in boys, and you can see development disorders in boys with very often an IQ below 70, but it seems more frequent. So there are elements of autistic delay, language delay, and then a whole litany of symptoms that are quite frequent, like hypotonia, or less frequent, like growth delay, microcephaly, epilepsy.
Okay, so this is all going to be quite detailed. Now, X3X, what is it? It's a gene. It's part of a really wide family of genes, and sometimes our genes are duplicated through their development. That means you can have a lot of different copies, variants, 1, 3X, 4, etc. X because it's chromosome X. And here you can see the phylogeny, how these families have evolved over time. And it is there to work on a helicase RNA. We'll see that later. Now, DDX3X, where is it? On the X chromosome, of course, but on the short part of that, which is called P, on the subsection 1,4. So XP114. That's just like the sat-nav coordinates for this gene, and we can see it here. the DDX3X gene. This is how it looks, and we've identified a lot of different variants that appear here on the screen, but just a little bit of information. Here, DDX3X has a friend on the X chromosome. It's called DDXY. Now, DDX3X, this gene, the protein that's coded by the gene, where does it express itself? Well, in a lot of tissues, not just in the brain. And we can see here, of course, in the brain, in the eye, in the endocrine tissues, in the respiratory system, but also in the digestive tract, so on an infection side, so through a lot of tissues. And if we were to focus on the brain and where it's expressed in the brain, well, almost throughout the brain, just except for the corpus callosum. And here you can see the different parts of the brain. I won't go into too much detail here, but suffice it to say that this is how the brain looks, the cerebral cortex. This is the small brain, and that monitors your balance. So I'm trying to go a little bit fast now, and we're going to talk about the gene function. Then we can get some questions and we can answer those questions. So what is this gene for? How is it used? So it is made on chromosomes. It's localized throughout different tissues, including in the brain. But what does it do, actually? Well, we're going to see this throughout the different presentations today. It's expressed in a lot of functions. And one of the main functions is the transcription of RNA. So what exactly is that? I've talked about genes. I've talked about proteins. Well, a gene is part of what's at the heart of chromosomes. So there are lots of different plans, lots of 20,000 genes in this core. And thank you for that information. I know I have lots of time left, but I think it's good just to focus on this. This plan does not come out of the heart of the system. We need to photocopy how that looks and use that then for manufacturing and changing everything. So that's where we make proteins, and that's what RNA is about. So this goes from the core to manufacturing part, if you like. And for different parts of manufacturing, DDX3X can help in that photocopying or copying of that plan, and then help the different parts be put in place, because our genes have different parts and we might have different copies of that photocopy. So you need to fold that sheet of paper up, and then you need to protect it and carry it outside of the core towards the endoplasma through the nuclear pores, and it's taken to the kind of manufacturing part. It needs to go through a door, and DDX3X is there to channel it, to help fold up that piece of paper, make sure it reaches the right place. And then what happens a bit later is that plan is turned into protein. And then the other parts, the other plans are also regulated. If you have cellular stress, so a cell that is infected, we also need to deal with that. And it's also involved in immunity, as we can see here. And maybe one of the questions we might have is, do DDX3X girls and boys have more infections, repeat infections? And it's also part of embryonic development, specifically in the development of neurons during the development of the fetus. I know this is a really ugly slide, but actually it shows you the same information. DDX3X is everywhere, involved in a lot of functions. Manufacture of that photocopy, carrying that photocopy to another place, what happens when that gets modified, how the protein is manufactured and made, and the rest. So thank you. I hope that wasn't too esoterical, too complicated, but thank you for your attention. And of course, if you have any questions, we can come back to this information and go over it. But thank you to Extraordinaire, the AnDDI-Rares line and deficiency line, and for this conference. Thank you, David Geneviève. So, questions after Valentin, if we can, please. We would like now Now to move on to the next presentation, which who is also from the Montpellier Hospital, CHU. So this is our genetician, Valentin Ruault. Welcome. There is a microphone here. Thank you very much, Helen, for helping out. Now, you sent out a questionnaire asking patients for their feedback. Tell us about that. Well, it wasn't exactly me, but I have flyers and posters here available. So please, please take one if you want to. But thank you very much for inviting me. Thank you very much for letting me take the floor. There, 10 minutes of David Geneviève. Imagine what it's like for 2 hours at the university. Okay, now I'm going to talk about GenIDA, and some of you have already used it, so you might be familiar with it. The title is in English because that's what the program was made in, but it's about caregivers and parents and their contribution to GenIDA, how that complements medical data that we as physicians already have. So in the US, the average time that a doctor listens to their patient is 11 seconds. That's not bad, but it's not great. In France, of course, we do everything better. It's 23 seconds. And of course, if you want to know what's going on, that's not very long. So why is GenIDA here? Well, we wanted to do a descriptive study of the most frequent symptoms. So when you have a pathology or a condition, that's the most common symptom. Why? Well, just to be able to answer your questions and to answer the family's questions who are impacted by DDX3X. Now, what we most commonly hear every day is, yes, doctor, okay, you've diagnosed this in my child, but what does it mean? What's actually going to happen? What's the next step? And without you, the answer would be, I don't know. So we're trying to give a better answer, actually. GenIDA is about representativity. Now, it's a French platform, so of course we have a lot of recruits that come from France, but as you can see, the spending, it's less than 50%, so over half of the respondents are not French, and that's good for something that is made in France. So we're mainly European, as you can see. I'm not sure you can see that the black is the UK, then there's Spain, and then fewer and smaller categories. So overall, once you have responded to this questionnaire, and for those who haven't, it's a questionnaire that's very long, but it's very detailed with a lot of questions that are broad to begin with, but that then ask general questions. What are the symptoms? Who is affected by this? And then you go through each organ and describe the impact, the date it started, the age it started, etc. And what I have been able to see and analyze, thanks to this platform, is graphical representations such as this. So the overall outlook that shows us the syndrome, the pathology. Vision seems to be impaired the most. Then we've got intellectual deficiency. We've got movement problems, very broad movement problems, behavior, etc. And right down to the bottom, and there are problems with cancer, just for 1%, and problems with smell, we have a 0 response. Now, these questions that may seem very basic to you, no doctor had ever asked previously. So the first question is the most important one. What is the main problem at home? What affects your relatives' everyday life? That's something that is never asked. And you as parents ask this all the time. And we never know how to answer that. So we know that for DDX3X, overall, it's attention deficit with or without hyperactivity. And that is the most difficult thing to deal with on a day-to-day basis. The second most commonly asked question is, what is the behavioral problem that impacts your everyday life the most? Well, that means, cutting yourself off from outside the outside world, that idea that you're just not able to connect with the outside world. And that ties in with the psychiatrical side of things. And we'll be talking about that later. But another thing that might seem very obvious to you, but is very useful How are things on a day-to-day basis? Does your child know how to do up their laces? Can they brush their teeth? No other genetic condition is described in this way. So all of this, for instance, do children at the age of 6 know how to do up their laces? But actually, it's about knowing what they can and can't do. We need that kind of information. Without that, we can't provide responses. So on an individual level, it's very difficult to answer that. Can your child tie their laces at 6? Will they be able to tie their laces at 6? But we have an overall idea. For instance, I have so many kids. This is what they know how to do at this age. This is what they don't know how to do. And it gives us an idea of how to predict things in adults as well. Has this happened? Has it never happened? Things that seem very obvious to you are very concrete and useful to us, and questions that we very rarely ask or have asked. So complementarity, again, we have the information from doctors, the information from GenIDA. Overall, GenIDA said basically the same things. That's logical. The doctors know at what age your child started to walk because you told the doctor, and then you told the same thing to GenIDA, or at least I hope you did. And then that can be very useful as well. And what's really interesting with GenIDA is that there are more graphical representations, as you can see. More questions are raised, and we wonder about cross-referencing. Not everybody is asking the same kinds of questions, so this enables us to make everything uniform. But I think the main takeaway message for this was ADHD. And when we launched the study, this was something that was almost never described for this condition, DDX3X. And now it is. It impacts families, it impacts individuals, but to a very high degree. Anxiety, this is something we will also come back to. I think that overall, we need to listen to families, listen to individuals, listen to our patients. And what's the next step? Well, we've talked about motor tests, psychological tests. We've got a lot of figures here. The Vineland study. I don't know if I have a laser to point. Great. So we can see that overall, the psychological and movement tests, which enables us to kind of set figures and see where a child is at. One of the strong points of that is verbal comprehension. We can see that in those tests on the Vineland grading or scale, we can see that verbal comprehension is something that's preserved well. So we need to base any learning on that. Speech therapists know about this, and that's a useful thing for them to know, to then be able to adapt their therapy. And access to communication, oral and written, how we get round any difficulties, maybe with access to communication. So this is all a bulk of work that we've done on this data, and we'll be talking about this in more detail, or at least Angela Morgan will be. Thank you very much. Thank you very much for having taken part in this, in the questionnaire. As we've seen, it's very important to know what the next steps are. And all of that is thanks to you. So thank you once again. Thank you very much.
In the after sales service you will get of the slides presented during this event. The next speaker comes from Australia. She specializes in speech disorders, and she's going to introduce a study in which French families are the most represented. Welcome, Professor Angela Morgan.
Good morning, everybody. Thank you so much for having me to speak here today. It's really such a pleasure. And I'll be talking about speech and language development in children with DDX3X syndrome. We have studied some boys with the condition, but Milou Kennis will talk later about the experiences of boys. So today my presentation is focused on females. And I'd just really like to thank Elana and Lottie, two talented PhD students in my team. You may have heard, have many emails from either Elana or Lottie, and they really did the hard work today. Why is a speech pathologist from Australia here today? Well, we have a lab, that's some of my team members up there, where our labour of love is really studying speech and language and how we can help children's speech and language development in children with rare conditions. So that's why I'm here. We have a research institute that is also based at a children's hospital there, and we also have the University of Melbourne, which is Australia's leading medical university on the same campus. So we've got teaching, research and clinical practice, and I still work as a clinician. I wanted to really make a point here about the fact that speech and language, the terms are often used interchangeably in society, but to a speech pathologist, these are very separate terms. And why is that important? It's really important because you need a specific diagnosis for your child to optimize the specific therapy, that targeted therapy, sooner rather than later. And it's only through targeted therapies, not just playing and encouraging, but really targeted therapies that we will make a difference. So when we talk about speech, it's quite intuitive. We're talking about the production of or articulation of the sounds of our language, so how we use our lips, mouth, tongue to produce those sounds. When we talk about language, we're more talking about content and form. So the meaning of what we're saying. Do children have a good understanding of words, their vocabulary? How are they using the grammar of their language? Are they using grammar appropriately, building up sentences? And it's also the comprehension, which Valentin talked about, as well as expression of words, sentences, and also social skills, word finding difficulties. All of this encompasses language. And that's what we'll be talking about today. We had, again, working in rare conditions, fantastic to have the collaborations that we have, because we have to try and work with families all across the world. So just like the GenIDA study, we also use a very online platform. We try and meet with most of our families, but language is, of course, a challenge. And you see here we had 38 individuals in this study, and around half or more of the families were French. So a very sincere thanks to you. The French really took part. And that was also from help with GenIDA as well, as you'll see later. So the mean age of people in this study is 8.7 years. For those of you interested in the specific gene change or spelling error, see here that we had a range of gene changes that were across the group. And for those people interested around in the missense variants, David spoke earlier about the 2 functional domains of the gene, and 10 of the individuals who had missense variants had those variants in the 2 functional domains here. And the 3 remaining changes were just outside those regions there. This is a very busy slide. I have loved Helene's the beautiful template, so I've gone with the colour here. But really all I wanted to show was that, you know, thank you so much to the families, because you are the ones completing all of these assessments, working harder than the clinicians. If you look at those 2 columns over here, families working hard. We do include children who are minimally verbal. So we'll talk a bit more about, there was a great question about absent speech versus speech earlier. And I wanted to say a big thanks to GenIDA, who also helped us really connect with the French families. I'll focus mainly on speech and language, which we've collected, but we'll also talk a little about feeding difficulties as well, which is something that speech pathologists also work with. So we'll start to talk about speech and language in a moment, but I really wanted to emphasise the importance of overall movement skills, because as we know, children with DDX3X syndrome are born with low muscle tone, so hypotonia, as it's called in the medical literature. And that low muscle tone is really pervasive, and that really can persist over time. And that low muscle tone, we know, is really a challenge for further fine movement skills, and we see delays in walking, etc. but it also has tremendous impacts on speech and also feeding development. So I just want to emphasize how important occupational therapy and physiotherapy is actually for stabilizing, supporting the motor system and helping also with speech and feeding skills. Also, further to the low muscle tone, children with DDX3X syndrome can have difficulty planning and programming movements that they might like to complete. So they might know that they could draw around a circle and think that, they could understand what that task requires, but actually planning their hand and programming that and executing that is really difficult. And that also can translate to speech. There's a speech disorder, speech apraxia, which I'll also talk about. So you can see when you're trying to understand the condition altogether that movement, underlying movement or motor skills as we call them, it's really important as well for speech and feeding. So I said I'll just talk a little bit about feeding development as well. So we know in early infancy, the low tone can also have impacts on a child's ability to latch onto a bottle or breast for breastfeeding or bottle feeding, challenges with maintaining a strong suck, fatigue during feeding, and also reflux. So these are some of the early challenges. We know for some of the children with low muscle tone, low oral muscle tone with an open mouth posture, we see persistence of drooling as well. And then for some of the children, the gastrointestinal challenges of reflux, constipation and other issues. So all of these together over time for some children can cause aversion to feeding and delayed feeding milestones. And for some of the children, we do see that about 1 in 5 children do continue to have some forms of feeding challenges over 8 years of age even. So I think that's an area where we could do a lot more work to support families actually. So speech development, Valentin showed very nice data from GenIDA where you'll have more information on this, but in our cohort of 38 individuals, a large proportion of children had developed their first spoken words, not too late or beyond the typical year milestone. But there were still a third of children who had not developed spoken words, even up to 24 years of age. And that's not surprising, given that we understand that 2 in 3 children that we studied, so here it's not a longitudinal study, it's just a cross-sectional study, we saw that 25 of the 38 children were minimally verbal. What do we mean by minimally verbal? Other terms are used in the literature that I don't really like to use, so non-verbal or the absent speech term that somebody used, but we refer to minimally verbal being children who have less than 40 spoken words. That's spoken language. And we use a tool called the communication matrix to measure what children are actually capable of doing. And they're capable of doing a lot of things and they're communicating very nicely in other forms. So we can see this tool looks at children's ability to refuse, tame, looks at social abilities and exchange of information. So all of the things that children and we all need to do with communication in life. There are 7 stages on this tool, going from a very early stage of development up until using symbols, pre-symbolic and symbolic communication. So this is where we're all at here as adults in this room, very fortunate communication. Sorry, I can hear challenges with the we can see that 100% of children who were minimally verbal actually were at this pre-symbolic stage. They'd all reached this stage. Some others had reached more abstract language. And then a quarter of children were able to reach that level 7 of combining symbols, signs, or words. Well, they're not verbal, they're not speaking. How are they doing that? Well, of course, they're absolutely still communicating. They're using augmentative or alternative communication. I find this a terrible term. It's the term that's in our literature. I think we could come up with better terms than this because I think that's not a helpful term for families, but see what we are talking about. We can have unaided forms of alternative communication. So this is where we don't have any external device. We're using our own gestures or we're using formal sign language. Or aided, where we are using some form of system. whether that's low technology, so it might be a picture board, picture exchange, communication book, or high tech, so digital devices or even speech generating devices. And so I cannot emphasize enough, this is where I feel we should be doing more. We should be doing more at an earlier age for children. There is a dreadful myth that pervades globally, particularly in the medical profession, not with our wonderful colleagues here, but that use of these devices will inhibit verbal development. That is not the case. In fact, it encourages your speech and language development. So if you imagine, if you are only able to verbally produce 1 or 2 words, how are you going to develop the grammar, be able to practice more complex and sophisticated language? We see already the children have stronger receptive or comprehension skills. Okay, so we're inhibiting if we can't sort of support the children to then be able to also learn to produce language in a more sophisticated way. And here we see, remembering again, this is one snapshot in time, but we can look across children of different ages and see the types of communication children are using who are minimally verbal. You can see in the younger age range, sign is very prevalent. And that's, you know, also for all children with typical communication development, where we use a lot of gesture in the early years. Sign continues to be heavily used up until sort of the early school years, or middle school years rather, and teenage years, when you see aids and sign is used more consistently, and sign alone drops off, because you see that aids are required because children are getting older, they're developing further, and they require a greater sophistication. Also, some teens and children find signing can be more isolating if others in their environment aren't using sign, whereas sometimes the communication devices can be more shared with others in their environment. So I just wanted to emphasize that. But the biggest thing that we were struck by is how many children had no form of device. So these were minimally verbal children who did not really have an AAC support. And I feel like this is a really lovely opportunity to encourage use of these alternative and augmentative forms of communication to really enhance and help with communication development. There were a number of children, the remainder of the group, who were verbal. Only 7 of those children were English speaking, and in those children we were able to do very deep assessments with my team to look at exactly what type of speech specific diagnoses the children had. And the 6 of the 7 children had apraxia of speech. So you recall I said earlier about the underlying movement or motor control difficulties, where planning and programming of movements is a core challenge. So apraxia is a speech movement disorder of planning and programming. So a child knows the word they would like to say, but they have real difficulty quickly and accurately sequencing all of the sounds together and producing a word with the correct stress pattern. So some of the features that you may have seen, the limited babbling, the delayed first words. You might also see vowel errors as well as consonant errors. That's quite more specific to a speech movement disorder. It runs across all of the speech sounds. Inconsistency of speech. So there are 2 forms of that. One is where a child might use a word, they use it a couple of times and you don't really hear it again for a little while, but it might come back and then become learned and automatized and used. The other form is where a child might have a word, it might be a complex word like helicopter, something very challenging, or even simpler words, and each time it's produced, they have to make their own novel plan, a new plan every time. And so often you'll see differences in the production. So for a word helicopter, 4 syllables, very complex, you might see helitopper, heiotta, hepiocta. So children add sounds, they omit sounds, they make unusual patterns. That's part of apraxia. And very frustrating for the children when they know the word and they just can't get their movement system to implement that plan accurately. The other challenge we talked about earlier was the underlying tone or weakness, and that goes across various systems that are important for speech. So if we think about articulation, Think about prosody, the lexical stress pattern of our voice that requires a lot of fine control of pitch, our voice, and also timing. Resonance. So for some children, they might have altered resonance. So in English, in French, and other languages, we have oral and nasal sounds, and you have to very quickly make those movements. If you have a lot of weakness there, that can be very difficult to do that accurately. So you hear altered resonance for children. Respiration. So we just take it for granted, being able to talk a lot on one breath stream. For some children who have already challenges with respiration, they could only get out a few words on each breath stream. And then phonation, how crisp and clear is your vocal folds working? Do you have weakness also in your vocal folds? So some of the children who have apraxia also have had a sign of dysphagia as well. Here we're going to listen to a child. She's an English speaker. She's an Australian child in our clinic. You see some of her features here, but in particular, you'll hear the apraxia of speech. Oh. Well, we hope we would hear, Helene. Sorry, it was working before, wasn't it?
Voilà, le temps de résoudre le problème, vous pourrez poser vos questions au professeur Angela Morgan à l'issue de sa présentation.
While we solve the problem, you can ask your questions from Professor Angela Morgan. I believe some.
So you'll hear young Julia. We've just made up a name for Julia. Thank you, Helene. She starts off saying the word hippopotamus. Pardon? No, never work with animals, children, or show videos. That's in showbiz, don't they say that? Videos are always problematic.
What's the long word for hippopotamus? Excellent. One of these things that you learned about. The long word for hippopotamus.
These the hippopotamus. So we're missing out some sounds. We're not entirely clear, but my goodness. Out a word like hippopotamus. The next thing she says is one other short word.
One of these things that you learned about. No, yeah.
Oh, sorry, everyone. Jamas. So for pajamas, she said jamas. So missing off the first sound, something that we hear. The next word that she's going to say is a very nice illustration of the word finding difficulties that we sometimes see. So she sees a picture of a triangle, but you'll hear how she produces that word. And she's given prompts from Olivia in my team, who was seeing Julia at the time, as we will call her. You'll hear Olivia prompting her the first sound and then giving her a bit more of the word. And you can see how challenging it still is for this young lady. And that word finding often can happen with apraxia. There are similar regions of the brain in which these features are underpinned.
What shape? So a square. It's a.
She said a scare. She was trying to say a square right off the bat. So she pulled something, retrieved a word that was not right, and now it's hard for her to actually go back to retrieve the word that is correct. So she sort of perseverates a little bit on square.
I heard you say the first sound. But is. There is triangle. Yes, got.
So nice to hear when she gets the word in the end. But you can see she knew the word. What a communication breakdown, how long it is and how hard it is to wait. fantastic that she got there in the end, but that's very illustrative of the difficulties that can be seen. The next young lady we'll call Sam. She has apraxic errors as well, but she also very much has the dysarthria. So you'll hear her voice is a little tremulous. She's not crisp and clear in what she's saying, but she has a bit more accuracy in the speech sound she's using.
Daddy will sleep all day.
Did anyone hear what she said? Daddy will sleep all day. Dropping in, Dad.
Dad will haircut. Dad will back home.
And then she said, Daddy had a haircut and then we ride home. So hard to understand still, but you can see how tremulous she is. And she does have tonal issues as well. And that's more the dysarthria coming across for little Sam. Okay. Oh, sorry, you didn't see her up there. Sorry, I think it's frozen. Do we have time? No?
Yes, that's fine. You have time.
Sorry.
The long word for hippopotamus. Excellent. One of these things that you would have been. Diamonds. Yeah.
Okay, well.
Daddy will sleep all day. Dad will haircut. Dad will back home.
She was just playing with the table. She doesn't have such a severe movement or motor disorder that was part of her tremor or anything like that. She just has a little bit of activity. Okay. So then we're moving away from speech production now to go back and look at language abilities and the Vineland, which many families don't exactly love filling in, I know, but can give us very valuable information. Here we looked at communication, language ability relative to daily living, socialisation and movement skills, and we see the lovely social strengths of language actually that come through. The other thing we noted when we look further into communication was that receptive language, as Valentin already told you earlier, was more preserved than expressive language. So that's a relative strength. You can see this, that children without DDX3X in the general population, this would normally be the typical range. So yes, we see language is reduced, but still there are some strengths that we can focus on. We also did a deeper dive into language here. This tool, the Children's Communication Checklist, looks at grammar. So how are children combining words? Are they using the correct grammar for their language? The semantics we talked about, or vocabulary. Coherence. So when children are speaking with you, are the topics a little bit tangential, or is there a nice flow to the conversation? Imitation, ability to imitate. Stereotyped utterances. So these are things like, hi, good morning, see you later, bye. So there's a real strength there for those stereotyped utterances. And part of that reason can also be because you've produced them so many times in terms of your speech or your sign or your other systems that they've become more automatized. So the apraxic elements to the condition have reduced by so many practices. So that's really important to note. And maybe also from an autism perspective as well, where we see stereotyped utterances. We also see strengths in non-verbal, of course, social skills, and also interests, specific interests that the children have. So really, the take-home messages, yes, you know, the term absent speech isn't a great term. There's a bit of a challenge with the human phenotype ontology. So what is that? That's what medical professionals use on their electronic medical records. And there are a set number of descriptors And we're working with the HPO, who are really fabulous and enjoy collaboration, to improve the HPO terms for speech and language at the moment, because a term like absent speech is really unhelpful and not accurate enough. Other terms you'll often see are just delayed speech and language, which also doesn't tell you anything really in terms of specificity. So we're working to try and improve that. But we do still see many of the children are minimally verbal, but they have, more preserved receptive language understanding. They also have social motivation as a real strength as well. So all of these things really tell us that use of aids and devices are going to help to give the children more of an opportunity to develop more sophisticated expressive language as well, and try and bring the expressive language up with where the receptive language is. Also, the high rates of speech motor disorders, they require a really specific type of speech therapy. It's not just going along and practicing sounds. There are set intensive programs that children can be using. There are now randomised controlled trials in the field of speech pathology, which were lacking for a long time, to show the benefit of these types of really targeted therapies. So prompt therapy, dynamic tactile temporal cueing, these are therapies we'd be happy to talk about and share information on further, but these really will help to encourage and improve speech and language development. So I wanted to say huge thanks. One of my best phone Zoom calls during the whole of COVID was with David Genevieve's group. David reached out to us because he could see nice synchrony between our groups, and that's really why I'm here today. Also Boris Chaumette, who's working with some of my other doctoral students at the moment, and a huge thanks to the different support groups and also to the participating families, because I think, as Valentin and David have nicely said this morning, really the work wouldn't happen without your support. So thank you.
Thank you, Angela Morgan. We've got a question online in Spanish. So Justine Ouakil, she's Spanish, French, and English. She's translating right now from reading the question and translating in or formulate it in English, unless you've got your headset as you want. But Justine is in the starting block. Sinon, mesdames, messieurs, le temps qu'on assimile la question, y a-t-il une question dans la salle?
Ladies and gentlemen, otherwise, do you have any question from the room? Hello, can you hear me?
Thank you very much for your speech.
Okay, lovely.
An online platform that we could contribute to. Would it be possible to share the link to the platform, or is it via the GenIDA?
For the GenIDA?
Yeah.
So GenIDA were part of our study, but we also had our own separate work.
And would it be possible for French children to contribute?
Yes.
via
Sorry, I
video
didn't talk further on that, but absolutely. So I think there were 16 or 17 French individuals out of the 38. We also had Spanish families, German families, Dutch families. So we translate our surveys into many different languages. Yeah. So yes, if you're interested in taking part, if that's what you're asking.
Yeah.
We just have had the paper reviewed quite positively, but it's under a second round review as they require. So that may come out soon. But yes, so we'll have the paper out, but we'll still keep collecting data. So that would be lovely. Thank you. Okay.
Okay, so we're going to get to know our 5 panelists. So it's about medical, paramedical, educational and schooling care and support practices around Europe and across the Atlantic. So it's a little bit of a cross-section. And the golden rule, ladies, is to tell us about your own lives, your day-to-day lives. And the idea is to know what's happening in your country. So maybe not just talk about your own personal cases, but also tell us what's going on in your country, what you know about other families as well in similar conditions. So are we ready to start this round table? Yep, we have an artist as well. So we can hear the translation. Sorry, we can hear you in our headsets, but we can't hear you in the conference room. So can you hear? So speaker is speaking in a mic. He's a man. I don't know if you can hear that male voice, Effie.
No, I can't hear a male voice. Oh, I can hear now. Yes, I can hear.
Ouais, donc elle ne peut pas entendre les lancements, ce qui va être fâcheux. Effie, can you hear me?
Yes, I can hear you.
And your mic, can you? Okay, nice. Are you able to speak with your mic? I think your mic is up, no?
No, this is my mic here. This is my mic.
Est-ce que vous pouvez allumer votre micro? C'est bon?
Could you switch your mic on? Great.
I have
Okay.
switched it on, yes.
Donc ça veut dire qu'il faut que j'ai une oreillette pour entendre ces réponses. D'accord? On est entre nous, hein, voilà. C'est pour ça que les tests, on n'a jamais fait assez de tests, pardon, excusez-moi.
Sorry, we're just still organizing ourselves. Okay, so I'm going to ask the first question and we'll go around the table, ladies. Let's take a look at a few photographs and you will tell us what's in each of those photographs. It's a member of your families. You will introduce them. The child in question, your child, and tell us when you were diagnosed, when they were diagnosed, present your family and, you know, when it was diagnosed. So maybe we can start in Denmark with you, Cornelia Klugman. You are mother of Emmeline, and she is 5, and I think we have a photo of her.
Thank you for the invitation, Camille, everyone. I'm very happy to be here. I don't think there's my photo yet, but can I anyway start? So this is me. I'm from Germany. My husband, Richard, who is American, and so we're quite an international family because the children were born in Belgium, and where we used to live in Brussels, and now we live in Denmark. We've lived there almost 2 years now in Copenhagen. And so this is our older son, Evan. He's nearly 8 years old. He's typically developing. And we have our little Uda, who is here at the moment being very well cared for by the helpers. She is 5 years old. When Uda was 6 months old, we couldn't detect any successful attempts at sitting up, so we were getting a little worried, took her to a doctor, and the pediatrician didn't know either what was wrong with her, but took her to a robot therapy, physiotherapy, and that's been very good. She's had this for years, and the therapist helped her to sit up, and also was practicing a lot of at home to crawl and finally to walk, and now she is she's running sometimes. And she was diagnosed, had a genetic diagnosis at 1.5 years.
On va aller du côté de l'Espagne avec notre plus française.
Let's move on to Spain now with our most French of Spanish mums. She is Justine, mother of Maya. You're vice chairman of the association DDX3X. We'll talk about that just after. But if we could start with hearing about Maya and her family. Thank you. So I am French. We live in Spain. The photo, which is about to come up, shows my daughter Maya. She is 9. She was diagnosed when she was 4. born in Spain. I was pregnant whilst in Spain, and in my case, the pregnancy was very tricky. There were some signs, all of the tests were coming back normal, but at week 34, I think, or the 32nd week, there was a brain malformation. So obviously, at that stage, you couldn't do anything about it. But there were various signs that were pointing in that direction. So here's Maya, she's 9. Her brother Helio to the left, who's 4, and the small, who's 2 years old. Okay, the photo's a little bit older. And Alvaro, the dad. So we had to wait for 4 years for the diagnosis. And I think by that time, we didn't believe we were going to ever get a diagnosis. But, you know, whatever. What we wanted was to know whether we could have more children. That was the main thing. That was the most important thing for us, actually. On top of course, helping Maya the best we could. But without that diagnosis, we did get to therapies and doctors that were very helpful. So the label helps for some things, but for others doesn't really make a difference. And I think maybe that's how we all feel. And the diagnosis didn't change the situation very much, but we got to see we just wanted to know whether we could have more children. And we wanted to meet other families as well. For us, it was really important to be able to talk to other families, share our experience of the condition with these other families. Okay, let's go to England now and meet Sadie, Sadie's mom, Effie. Good morning, Effie.
Good morning. Can you hear me?
Yeah. Yes, perfectly.
Yes,
So just
you.
a quick presentation of your daughter.
Yes, so that's myself and my daughter, Sadie. She is now 19 years old. And she was, we first got the diagnosis when she was 13 years old in February 2018. However, I noticed that the letter from the laboratory was dated much earlier than that in July 2017. And I've never yet found out why there was such a delay before I found out from when the geneticist was told. So I suppose similar to your last speaker, it didn't make a huge difference to how her life was at that point, but it made a big difference to me because I was able to meet lots of other people who have DDX3X. I have met them in person. Just 2 days ago, I was spending time in New York with one of our American friends with her daughter with DDX3X. So it's made a big difference to me to find out about other people with the same condition.
Denmark, l'Espagne.
Okay, so thank you. We've done Denmark, Spain, the UK, and now France with Camille. You are Nell's mom. Can you just quickly introduce yourself? Yes, Nell is our eldest daughter. We have 4 beautiful daughters. Nell is 12, and the DDX3X diagnosis happened when she was 6.5. Of course, we didn't wait for 6.5 years to realize that she had problems with all of her development. And during the first years, we had physio, we had speech therapy, we had various motor, occupational therapy as well. And she had a brain scan when she was 17 months. I was pregnant with our second daughter, Ines, and that identified cerebral or brain malformation. And the brain scan really was done to make sure that my second pregnancy or second child would be all right. So this is our family this summer. There's Nell in the middle, Ines 10, Avril 10, and Ellie 5. Thank you. So maybe you know Emily in Paris, but we have Chelsea in Paris, who is the manager of DDX3X together with Camille. You've come to us from the US. Thank you very much for being here this morning. So let's just go back a moment, if I may. How many people are diagnosed in the US? Do you have any figures? And maybe
were you able to put the slide up?
No
worries if not, it's okay. Okay, that's okay. So right now we have a little over 1,100 known cases in the world. Hello, is that better? Right now we have a little over, sorry. Right now we have a little over 1,100 known cases in the world. Of those, 415 are in the United States. 665 are in the rest of the world. And of those 665, 433 of those are in Europe, 86 right here in France. Perfect. Okay, thank you.
86 en France, Camille, mais il y a quelques années, c'était
86 in France, Camille, but a few years ago it was 40. Yes, when Nell was diagnosed in 2017, there were approximately 40 cases, known cases in France. And I was talking earlier to Céline Ringimbert, who said that when their daughter was diagnosed, she's called Eve-Marie, there were 2 or 3 cases in France at the time. Because the syndrome was recently discovered, now it's something that people look for. They screen for it. So the more we screen, the more we find cases. But the doctors said that the DDX3X syndrome is largely underdiagnosed. Well, there is an example in the Lille University Hospital where Nell is actually taken care of. There was a doctor there who said he did not necessarily know whether there were many more cases. Yes, that's something we discuss among families. The information may be reported through different channels. For instance, the census of children or families carrying the syndrome may go through the families, through the associations, through the doctors themselves. But communication and exchange of information is not necessarily really well organized. It's not this. There isn't a very good flow of information. That's why we encourage you to fill in the questionnaire online on the platform and talk to the doctors, and doctors should talk to each other, and families also should talk to each other and help each other identify cases. They should really try to contact other families, and that's the whole point of the Extraordinaire Association. So if I understand well, your children were diagnosed at different ages. Is there a difference when the diagnosis happens at an earlier age or later? I would like to start by asking Effie the question. Is there a difference when the child is diagnosed at an early age or a later age, as is the case with this particular child?
So that's an interesting question. I think in terms of my personal experience, it did not, the late diagnosis meant that we couldn't get much early intervention. But even if we'd had that diagnosis at the time when she was born, there was so little known about DDX3X that it might not have made much difference. But I think where it will make a difference is in the future, because as we find out more about DDX3X, we can look for particular therapies that will be of help. So, for example, I have a friend with a daughter with Rett syndrome, which is another condition that is an X chromosome condition, but much more known about because it was discovered earlier. And she has from birth been monitored by many specialists to see if she will develop certain conditions that she hasn't developed yet. For example, a spinal surgeon to see if she will get problems with her spine. Whereas my daughter, who is the same age, was never monitored by a spinal surgeon until she developed issues with her spine, where she has 3 conditions, scoliosis, kyphosis, and lordosis now, that developed very quickly during puberty to quite a severe degree. When we realized she had these conditions, we were then recommended to have, for example, physiotherapy on horseback. But when I went to get physiotherapy on horseback, we were not able to access it because the physiotherapist said her scoliosis is now too far developed to safely use that therapy. So I think that for the future, early diagnosis is going to be key to be able to monitor and provide support as soon as, or before even, conditions are noticed within the child. So yes, I think early diagnosis in the future is going to be really, really useful.
Un diagnostic précoce vous semble très utile à l'avenir. C'est votre avis aussi, Justine? Vous avez
early diagnosis will be useful for the future. Justine, do you share that opinion? Would you like to add something? Absolutely. Depending on what age a child is diagnosed, makes a lot of difference. The earlier, the better, because we can anticipate on certain symptoms, as Dr. Ruault was saying. Being aware that your child suffers from that syndrome means that you can anticipate on future symptoms. Maya, who's 9 years old, has recently been diagnosed T1, which means that she has autism spectrum disorders. And she also has a deficit attention hyperactivity disorder at the age of 9. And as parents, that's something that we monitored. Obviously, we were looking for the symptoms, and the doctor said, no, don't worry, autism spectrum disorders, no. She's got all good eye contact, so, no risk. And yet, at the age of 9, we finally diagnosed that she suffered from autism spectrum disorders. So knowing beforehand, earlier, when the child is diagnosed at an early age, will help you anticipate for future symptoms. On the other hand, I know that the experience may change from one person to another, regardless of the age at which the diagnosis is made. For some people, it means that you can actually come to terms with the disease, you have a name, you know what your child suffers from. But for other people, it also opens up the door for many different questions. We know it's called the DDX3X syndrome. Okay, now I know what the disease is, and so what? You start looking up on the internet, Googling the disease, you don't find anything or not much, and that's the reason why we're here today. And that's all the reason why there are associations around so that you can talk to other people who suffer from the faced with the same challenge, and you can support each other. Absolutely. I mean, Maya was diagnosed when she was 4 years old in Spain, and there were 4 cases. It was 2018. And so we met with the other 3 families, and we decided together with other mothers after a couple of years to create the DDX3X Spanish Association, because in Spain there was nothing. There was nothing at the time. So we decided to create an association. So, well, for many reasons. First of all, to push for more research. There was nothing in Spain. There was no research whatsoever. So we wanted to get things rolling and start the first trial study, thanks to the zebrafish that we will talk about this afternoon. And we wanted to encourage research on the national level, but also internationally. We tried to contact all the professionals who are familiar with the syndrome and work on this syndrome, both in Europe and in the US and Australia as well, and other countries where research has been conducted. And we wanted to provide support for the other families, because that's one of our missions. We really want to provide support to families when their child has recently been diagnosed, help them cope with the problem for administrative matters, because obviously, depending on the country, there are programs, but there are also administrative issues. And so we try to provide support to the families. So we understand, ladies and gentlemen, that there was a before the diagnosis and after the diagnosis time. Cornelia, could you tell us what difference it made in your child's life, your family's life as well, before the diagnosis and after the diagnosis?
Some of the therapists or the doctors told us that it wouldn't change very much, that the therapies mainly address the symptoms of the disability. For example, that there's very little speech, so we do what we can to help her speak. But in this context, I'd love it if Angela's research and other research on this was more well known, because, for example, you told us, we participated in your study, and you told us that a lot of the girls have a fracture of speech. And if this was also more well known in the commune who pays for the therapies in our place in Denmark, then this could automatically be said, okay, this is a very severe speech impediment and she needs intensive speech therapy. And with this, we really don't have enough. We have speech therapy 1 hour a week paid for by the commune. I'm very lucky to have a generous employer who helps us, who helps our little daughter, and pays for more therapy. So we pay as private speech therapist twice a week on top of that, and our employer will pay, my employer will pay me back with a different technique to help Uda at least develop some speech. There is some speech, but very little. Other therapies also, where we started the therapy Bobat kinesiotherapy before a diagnosis was given. And when it was given, it was confirmed that this was the right therapy. Also, the ergotherapy started a little later. It's also totally standard, I think, for this diagnosis. Of course, it was a very hard blow to get the diagnosis. We were, was it fairly deuil? We had to also grieve. The future our daughter is probably not going to have, but still, it helps you to get to deal with it, to know how to expect some things. And also in Belgium, where we lived before, and I think also in Denmark, you get some additional medical exams because of the diagnosis that otherwise you probably wouldn't be given.
Camille, du côté
Camille, in France, what happened? Was there a difference before the diagnosis and after diagnosis? We know that children are being monitored and helped by speech therapists and physiotherapists. Now, you yourself are a speech therapist, and your husband, who's here somewhere, is a physiotherapist. Is that an advantage, or maybe not 100%? Well, honestly, I believe it was fortunate. I mean, we were alerted much earlier because we were able to spot the initial delay in learning to speak, becoming verbal, and we were able to trigger a certain kind of action earlier. But whether the child is diagnosed earlier or later, well, the fact that she was diagnosed at the age of 6.5 did not make that much difference because we already had started a number of therapies before she was formally diagnosed. But I remember the day the diagnosis was confirmed on December the 8th, 2017. I remember the day vividly. I went on the forum online to contact families whose children had DDX3X. We also contacted an association which the geneticists had given us the address for, and that helped. Because, by talking to other families, we felt like we could share our experiences and maybe share best practices, how to best deal with the problem. And we felt supported. We did not feel so isolated. Although, again, in our case, it did not change the therapies themselves. It helped us anticipate and look for a certain number of symptoms that you have to pay attention to. The DDX3X syndrome, like all X-related syndromes, rare diseases, have different expression levels. And our daughters have the same kinds of symptoms, but they may be expressed at different levels. Nell, we can't, for Nell, we haven't seen any risk of anxiety, which is normally very present in many children, but anxiety may appear in many ways and earlier or later. So the fact that we know that this is one of the symptoms that appear in the profile is something that helps us. Just a word on the strength of associations, of how much the associations can help parents once a diagnosis has been confirmed. What you do in the United States, can you say something about, the power of the association, how much it can help families cope with the disease?
So I think, and two, just to speak to your earlier question about the importance of early diagnosis, what we see the most in the US, and we have people from other countries, of course, that come to us when they're diagnosed, is that feeling of community and really having the opportunity to connect with other families. Even if it's in just a social setting, we use our Facebook group a lot where individuals, can go on and say, for example, my child's dealing with anxiety right now. What are other people using? What medications are working for you? Or what therapies are working? So I think that the early diagnosis piece is very important for that reason. Additionally, in terms of support that we are able to offer, our primary function is to connect families and then, of course, raise money to fund research to find therapies and treatments for DDX3X. Often, whenever a family comes to us and says, we've just been diagnosed, what do we do? The first thing we do is send them to the Facebook group where they can connect with other families and other caretakers and others that are dealing with the same things. We don't offer specifically recommendations for care, but we do offer an understanding or a sort of overview of what is available, and again, what other families have found that works well for them. I also want to mention that right now we're getting ready to launch a natural history study, which will help us not only in the US, but all over the world to understand the progression or the natural history of the disease. And understanding that will be very helpful to providing recommendations for treatments and therapies for families.
Voilà, mesdames, messieurs, je vous rappelle que vous pourrez poser des questions.
Ladies and gentlemen, you will be able to ask our guests, all four of them, questions, including Effie, who is online. Effie, don't worry, you will not be left outside. And the next question is for you, by the way. On the chat, Gwendoline is checking the questions, and during the panel discussion, we can deal with the more general questions this afternoon. So could you explain the major challenges you're facing on your daily life with your child? Has there been any evolution, Effie, with Sadie? You said anxiety was your major challenge?
Yes, so I know you will hear later on from Dr. Martin when she talks about the bingo study that my daughter, along with many others, were part of. One of the interesting things about finding out that Sadie has DDX3X was that I already knew lots of other people with similar conditions from other support groups, but I wanted to find out what was really specifically different about DDX3X from other conditions. And this is one of the things that the bingo study has managed to identify. I know that I think Camille said this isn't an issue for her daughter, so it is different for every child, but anxiety is a huge issue, and one that when the bingo study, we'll talk later on, that they found that was very different in DDX3X. It was a specific problem that other children, similar children with intellectual disability, did not show to the same extent. And Sadie's anxiety comes from sensitivities to sights, to sounds, and to situations that cause her to become overwhelmed. And it's finding out how to help her deal with those anxieties has been really, really important. In fact, we got an autism diagnosis quite early on from a clinical psychologist, even though they said they couldn't really do the normal diagnostic procedures with Sadie because of her intellectual disability. They gave us the diagnosis because in day-to-day life, it was the behaviors caused by that anxiety that were the most difficult to cope with. Now we have found lots of things that have helped, such as deep pressure therapies, big tight hugs, using weighted blankets, being able to avoid triggers, identify and avoid triggers that cause those anxieties have really helped. So there is hope out there for people who are finding that their children are exhibiting behaviours due to anxiety. It's a difficult thing to treat, but there are lots of things that can be done. So I think finding out more about anxiety, more about the causes of anxiety in our children, and finding out how to treat those is very, very useful for families.
Votre côté, Justine et Cornelia, ce sont des problèmes pour Justine de communication, pour Cornelia des problèmes de langage notamment.
So Justine and Cornelia, you have issues of communication. For Cornelia, problems of language. Can you tell us about the gestures? Yes, Maya, who is 9, is minimally verbal. I would say non-verbal, but I believe she must have about 15 words. Mommy, daddy, auntie, very limited vocabulary. So we were always told to try to sign, to make gestures, but not sign language. It's too complicated. Macathon does not exist in Spain, so we invented our own signs, which was recommended, and it works well. For example, this gesture is for the scooter, but for Maya is now 9 years old, and we would like to increase her communication with other people apart from the family. So we now have a communication device with a tablet with some dynamic pictograms, and it seems to work. Her understanding has improved a lot. Until the age of 4, we weren't really sure of what she understood. So the pictograms were a bit too difficult at the time for her. But we started from the age of 5, and now we have the tablet, which started at the age of 6. But it's difficult for us as parents to change the signs from this sign for scooter to finding the right pictogram on the tablet. But thanks to a speech therapist and the professionals in her school, we really have seen progress. And for her, it's a great support when she is frustrated because she can't speak, because in this way she can communicate better with us. So in Denmark, you use a sign language which is specific to Denmark? Yes.
The French one, Méthode Sésame in Belgium. And this one is a little bit different. Some of the signs are the same, others are different, but it's the same principle. I think it's a simplified sign language mainly for the use with people with disabilities. And this is a very strong point of the Danish system. UDA is a wonderful inclusive kindergarten, and not only the specialized pedagogues who are employed there to work with the children with disabilities and the speech therapists, they know this sign to tell, but also most of the other therapists, the leadership of the kindergarten. And this is absolutely amazing. This was one of the factors that made us decide, okay, we're moving to Denmark, because their level of the inclusion they provide is just so good. It's really a great kindergarten, and we are sad that Uda will have to leave it next year at the age of 6, because it will be recommended that she go to a special school. And this leads me to her biggest difficulty. It is communication and speaking, because how can you know what is in someone's head if you can't get it out of them, if you can't understand it? Yeah, Uda has also, maybe would be classified as non-verbal, maybe minimally verbal. There are probably over 40 words, but most of them she can't pronounce properly. So my husband says, who does so much work with her at home, he says, yeah, for the last speech test, it's good that I was there because I speak Uda. The way that the speech therapist asked her the questions, it just didn't really work for Uda. And when Richard rephrased it in different ways, Uda managed it, and she knew what was requested of her. So yes, the intellectual disability is what I would say the greatest problem. Yes, I mean, sadly, she'll probably never be independent. It has to do with toilet training also. It's not yet toilet trained. Will it ever really work? We don't know. But yes, she will go to a special school. Yeah, if it has been. Do you want to come back to the schooling later, or shall I talk a little bit about this?
On va laisser peut-être parler Camille et puis ensuite parler effectivement évoquer les aides.
Well, we'll let Camille speak and then we'll talk about the specific support you get in each country. Camille, I guess it's a difficult thing in daily life. The lack of initiative, you talk about a weakness in activities. What do you mean by that? Well, in our daily life, what is really most difficult to cope with and what is requiring most attention and energy is this lack of initiative. Nell is a very curious little girl, but she has trouble targeting her curiosity. She moves to different things, and it's we have to be present constantly. We have to have a dedicated ear, so to say, 24/7, to see how can we use the present situation to make it beneficial for her to learn something and to take pleasure in it so that she actually acquires something. So we have to be constantly on the lookout for what she's doing and what she's going to do with the situation. Ladies, I'm going to ask you, as Cornelia was suggesting, can you pick specific support that you get in your country? First Cornelia, as she took the microphone, and then Effie.
Everyday life is possible like this, where we take most her therapies, 1 hour of speech therapy, 1 hour every 2 weeks of physiotherapy, and 1 hour every 2 weeks of ergotherapy takes place in the kindergarten. It's not only that, but they also teach the kindergarten pedagogues how to do the therapy, so it has a multiplicator effect. But of course, we'd love to see more face-to-face time with therapists also. So this doesn't take any particular effort from us, of course, at home to do the exercise again, but the fact that it's integrated in kindergarten makes life easier for us. But for the speech therapy, we take Uda twice a week downtown by bike, and this takes a lot of time, of course, and this wouldn't be possible for us without my husband, who has a lot of time to give to Uda. Makes possible that I still work part-time and even abroad in Belgium, where I used to work before, so our life is a little complicated to organize. You said a particular aid help that she has, which you'd like to know?
La façon dont vous êtes soutenu particulièrement qui pourrait inspirer le public.
Yes, the way in which you get a specific support and that could help others, something that exists in the country where you are and exists maybe elsewhere, and which is beneficial.
In Belgium, we would have had an inclusion also probably until the age of 6 in the preschool. My employer would have paid for a full-time assistant for her. And whereas in Denmark, they say this isn't really inclusion. If you need one full-time person to be all the time with your little girl, this is not really inclusion, because she can't do anything autonomously with the other kids. Whereas down in the kindergarten, it is still possible. She's being helped to play with them, with the other kids. Many kids, they enjoy playing with her. They love to make her laugh, because like when DDX3X girl, she's a very jolly character. She's easily amused. Yeah, I think the way they do inclusion in that kindergarten, with all the therapists knowing the sign language and using it, this helps Uya a lot to get her point across. also she does use a lot of the signs, not all of them perfectly, but well, if you know her, you will know what she means. And also the fact that we speak with her in our native languages. I want to stress that also, because I think too many doctors still tell parents, oh, your child has an intellectual disability, better use only one language with her. That's a lot easier for her. But I've learned more and more, I've heard from you that it's okay to use your own language. I speak German with Uda. Richard speaks English in the kindergarten. She learns Danish, and she understands what we want from her.
Effie, un exemple particulier?
Effie, can we have a specific example maybe or in the UK?
Yes, of course. Most of my daughter's therapies took place in her school. So different from other countries that I hear about, in the UK, most therapies, if the child is in special school, happen during school time in the school with medical professionals such as physiotherapists, speech therapists working in the school. But I would say that the one therapy that I did have to find separately for Sadie that made the biggest difference for her was music therapy, which you have to get funding for. It's not generally available through our health service, but I've applied for funding many times to get music therapy for my daughter, because I think it really helps with her communication. It's playing on one of her main interests, which is music. Most of her week is currently made up with attending music groups and events. And where she finds spoken language difficult, the language of music is absolutely her language. I noticed you say before you speak Uda. Well, to speak Sadie, you have to sing. And if you sing to Sadie, her eyes will light up and she will just engage with you and go, you know my song, this is amazing. So, so music therapy has made the biggest difference for Sadie.
Voilà, l'école inclusive au Danemark, la musicothérapie.
Inclusive school in Denmark, music therapy in the UK. In France, Camille, in a few words, a specific thing, and then we'll ask Justin and then Chelsea. Okay, well, I believe we were lucky because very quickly we assumed what could help her. And when we saw that there was a lack of communication tools available, we trained immediately into Makaton and sign language. Is it due to the fact that I am a professional or that I am a mom? And very quickly, I introduced Makaton, which she used right away. Or in France, we are lucky to have a lot of treatment guidance, and we have the possibility of exchanging with specialists and families. There's no ideal journey between the school in a specific school or in a normal school or whatever. The important thing is to have enough sensitivity from the physicians, professionals, and family to know what is the best for the child. And the child is the one that responds or not. And Nell has a specific mantra. Yes, she says, do like everybody else, but in her way. And Justine in Spain, if we think of school, it's true that there's quite a strong inclusive educational policy in Catalonia where we live, but it didn't work for Maya, because she was in a class of 25 children from the age of 6, and it was difficult for her to be surrounded with noisy children, and it was very difficult. So we moved her to specialized education, And we're lucky enough in Spain, you are certain to have a place for the child in the specific school, and she could be accepted in any school we chose. So we went from treatment after school to as Effie was saying, everything in the school. So she has speech therapist, physiotherapist, everything within the school. We have taken on by adding treatment with dogs, animal-assisted therapy, contact with dogs, and stimulation. And this has helped her a lot, I believe. And now we're starting horse therapy, equine therapy, because up till now she was a bit afraid of horses. So she managed to overcome this fear. And last week she rode a horse. She got onto a horse, and we're going to see if this adds any benefit for her. And in Spain, this is very common. There are 50 cases in Spain now, and out of the families, I believe that half of them go through horse riding therapy or equine therapy. You can, and this is beneficial. So therapy with horses and dogs very quickly in the US, a specific practice that could inspire Europe or France.
I don't know that we have a specific practice that could inspire you. In the U.S., it varies greatly based on what state an individual lives in. But I will echo the equine therapy. I think we have a lot of families that use hippotherapy. Also in the UK, music therapy. Our children also, whenever families first join the community, we hear over and over again that their kids love music, water, and animals. So basically anything that falls into those three categories is very helpful.
La musique, les animaux et l'eau. Dans quelques instants, la
So
parole
music, animals and water. So now, ladies and gentlemen, you have the floor. If you have questions for our five guests, we have learned in the meantime that there are quite a lot of questions for the guests and our specialists. Okay, so we'll continue for about 10 minutes. But before that, ladies, in one sentence, what is your ultimate dream if you had a magic wand? Sorry for this expression. Camille and then Effie. Well, we should continue to be close to the needs of our children, to adapt as much as possible, because we ask them to adapt to society, but society has to adapt to them. And thanks to that, we'll be able to continue seeing them grow up. Okay, being close to the needs. Effie?
Hi, yes, my dream for the future is that the researchers and doctors become fully aware of the causes and effects of the DDX3X mutations across the world, and that they share and use that knowledge to improve the lives of families affected like mine and families in the future who may be affected.
Justine, pour vous, c'est...
Justine, for you, what is your dream pre-birth test? Yes, well, I would like to thank all the researchers for their work, and please continue this work so we know more and we can help our children, and also maybe improve their future life, and hope that they can grow up in a society that is more inclusive. And not everything is linked to the medical field. And what about the prenatal test? I don't know. It depends on the countries. In Spain, DDX3X is not included in the tests that are not before in the prenatal tests. in the short term, that would be a dream, really, if we could detect DDX3X in utero. Cornelia?
I have been told that the special school where Uda will go to is a very good one. I'm sure she'll be well taken care of, and she'll learn a lot of things and enjoy herself. My dream would also be, like many of yours, a more inclusive society where maybe special schools wouldn't be needed because all the professionals to help would be there to help the kids in a standard school. And therefore, and now I have also a request mainly for politicians that carers and health professionals would be better paid, because that's what we're all worried about. If we think our kids would probably need help all their lives, just like elderly people. We don't have enough carers in any country in Europe, and all this needs to be provided.
C'est un sujet évidemment qu'on a en France.
This is obviously a major topic in France. Oh, Chelsea, I didn't give you the floor. Go ahead for the final word.
No, that's okay. Really quickly to your point, Justine, I do know of 2 cases that have been diagnosed in utero. Both are in the UK, I believe. And then, of course, I think the same as everyone, that you know, a more inclusive society and better treatments and therapies for patients.
Très bien. Merci beaucoup, mesdames. Vous restez un
Well,
instant.
thank you very much, ladies. I think we can give them a round of applause. Cornelia Klugman, Camille Stoven, Justine Detouche, and Chelsea McCarty, as well as Effie Fenton in the UK. There have been questions to the doctors that were answered directly, thanks to Gwendoline, so we're not going to share here. Just maybe questions to the 5 guests in the 10 minutes that remain before lunch. Hello? Yes, really, what you say is very important to us. Our daughter was diagnosed last month, and we are thinking of a 3rd child, and we are wondering what this diagnosis is going to change for our daughter, and what about the 3rd child? Several of you had children afterwards. How did your pregnancy go? What tests were made in order to eliminate the risk of having another child with the syndrome? Well, she was the eldest of our daughter, and the agenda worked well because Nell's diagnosis arrived after I was 1 month after I was pregnant for the 4th one. So we at the time thought it was a teratogenic factor, maybe. So if we'd had the diagnosis before, would we have taken the risk? But according to the medical world, they say we have no more risk with a 2nd or 3rd pregnancy. But would we have changed our way if we'd had it before? I don't know. Justine, well, in Spain, we had the diagnosis before, and this is why we had other children afterwards. And in fact, they carry out a test. I believe it's at 10 weeks of pregnancy to see if the child has the mutation. This is what is done in Spain. Any more questions? Do we have questions online for our 5 guests? No? So everything takes place here in the auditorium. Well, my daughter was diagnosed a year ago. Take your time to reformulate your question. Don't worry. You can take the floor afterwards. The person was getting emotional, couldn't ask the question. Sir, do you think that your children are aware of their disability? Do they express this awareness? Well, this is what we were talking about last night, in fact. We had to use the word handicap or disability on the day she was diagnosed. And then we had to use the word to get a kind of vaccinated. And Nell and her three sisters are aware of the fact that she's not disabled, but she has a disability. And we don't want to paint the devil on the world. On the wall. We just say, well, this is what it is. And this is the decision we made to put words on situations and on things. And we feel everybody feels better with that. And Nell is aware of the fact that she doesn't function like the others. And she expresses it. Well, we're lucky that she is really verbal. So she says that she has a DDX3X syndrome, that she has a disability. What is her degree of awareness? No one can tell, but I don't know if she realizes that there are things she'll never do, but she continues saying, I want to do like everybody else, but in my own way. So she's aware of the fact that she has a disability. When she comes back from school with some homework, she says, I have homework to do.
Thank you. I was interested in the attentional challenges of the children, and I suppose thinking about that impact on therapy and whether or not any families have shared perhaps trying Ritalin or different types of medications for the attention and whether that's had an impact on learning, speech learning or other learning for children.
In our case, we just started medication for attention disorders, Ritalin, but in Spain it has another name. So we've just been using it for 2 weeks. I can't tell you if it has an impact or not, but it's very frightening, I must say. For parents, some medication is very frightening, always. It took time, but in Spain, they never started treatment before the age of 6, 7, or even 8. So we just started. Maya is 9, but I can't tell you about the benefits. I know that other families started treatments before Maya, and it seems to work. But sometimes it's difficult to have the right medication and then the right dosage. This is very complicated. But for those for whom it works, there are real benefits on learning. Well, ladies and gentlemen, it's almost 12:30. You will have understood that this kind of event, the interest of this kind of event is to exchange. So we'll have an hour to exchange. But before that, we have one last question online. Please stay connected with our friends. For our friends who are online, we will start at 1:45 sharp Paris time. Stay connected. But before that, before we stop, there's one last question on the chat. Gwendoline, can you tell us? A question for Chelsea. Someone is asking, out of the 1,100 people, how many are over 30 years of age, and have there been clinical studies for that cohort?
Unfortunately, I don't have the answer to that question. So right now our count is 1,180 patients. Anytime I fill out a form that wants me to answer the question of how old people are, usually say that we have maybe 15 to 20% who would be over the age of 30, or I'm sorry, over the age of 20. I think the oldest case that we know of is 50-plus-year-old woman in Israel. We know of a couple of other 50-plus-year-olds in, I think, the UK and the US as well. In terms of clinical studies right now, there are not clinical studies being conducted in any way for DDX3X. However, we would absolutely hope to have participation in our natural history study from individuals of all ages. So I'm sorry that I don't have a better answer for you, or a more direct answer.
Ok, voilà, c'était la dernière question. On se retrouve donc ici à 13h35-40 pour un démarrage à 13h45 précise et donc respecté.
So back here at 1:35, 1:40 to start at 1:45.
Six o'clock. So the next presentation is about psychiatry. It's a word that often people are afraid of, and our presenter is going to try and explain it. Boris Chaumette. Good afternoon to you, doctor. You are a psychiatrist, and in your job, you meet a lot of families, and so you have noted a lot of different symptoms and therefore a lot of different treatments and responses. So please explain to the families listening what exactly psychiatry is all about and reassure them. So please, let's listen to the story that Dr. Boris Chaumette has to tell. Thank you, and thank you for hosting me here. It's great to be here. When people talk about psychiatric wards, people are generally quite afraid. And yesterday, there were 3 DDX3X patients I was counting over the last few years that I have. We have a former neuropsychologist who's here as well. And a lot of families wonder, why psychiatry? My child is not crazy, so why do I have to go to a psychiatrist? And we don't just look after people who are very severely ill in psychiatry. We also deal with patients who have genetic malfunctions and need psychiatric help.
Should do my slides and talk in English, and she said, "No, please, Boris, don't talk in English. Please talk in French because your accent is terrible." So je vais parler en français, désolé. J'ai laissé quelques slides en anglais pour que nos collègues internationaux.
So I've left a few slides in English so that you can follow more easily. And this is something that I borrow from people who've carried out this study. So you have the study in France, the GenIDA study, and 2 other studies, former studies that have been published. And you see that there are a lot of different disorders in this DDX3X, which is to do with neural dysfunction. So intellectual disability is one of them. Almost all patients have that to different degrees. Coordination problems, so lateness in speaking, warning, hyperphagia, sleep problems, autism disorders. That's a minority, I would say. Behavioral, ADHD, and even epilepsy or seizures. In St. Anne Hospital, we have neurosurgeons, not just psychiatrists, and we're familiar with all of these kind of problems. But what's interesting to note, and what was said this morning by Valentin, what you have fed back to us is the main problems. So behavioral problems with problems of attention deficit. That's what most families say is important. Now, I'm just going to go through this. I've tried to break down brain cognition. I know that this might seem a little bit simple for those who are experts in the field, but let me just try and explain this. Brain cognition is very complex, and it includes various different functions. So there are things to do with memory and learning, language, the executive functions, how you plan an action. So if you need to go shopping, you prepare, you take your money, you shut the door, store, you take the bus, etc. Sequences that you plan in your mind. So they're called executive functions. Then we've got complex attention. So being able to focus your attention on something specifically, and then being able to withdraw from that attention. Otherwise, you would stay stuck on it. So social cognition as well, how you understand emotions, how you interact with somebody else, how you know that at one point you have to stop interacting because there's no point anymore, and how you strike up a conversation or end a conversation, and more functions around perception and motricity. Motor skills, and these functions are difficult, and so when you change one of those, it can have an impact on the whole system. And for genetic disorders, some very small malfunction in one place can impact the whole system. And let me just give you a few examples. This is a kind of normal development. It's in a kind of star shape. We're going to try and use stars. Here you can see it's all fine. Everything is aligned. Everything is represented properly, as you would expect. I don't like to use the word normal, but obviously that is the underlying message. It's optimal functioning. Now, if something is different, for instance, memory and learning, then you have a deficiency in this field. So problems reading, problems learning to write, to count, or your visual spatial orientation, geometry. It could be any of these. Everything else is working, and there are no other problems. But this is what we call the deficiency, learning deficiency or disorder. And we have to do cognitive training or remediation to try and boost that function. And it's useful to use this star because it means we can use maybe another function to rehabilitate the disorder. So for instance, when you say that you have a memory problem, maybe we can use a strategy from the executive functions to consolidate that memory. And that's exactly what colleagues do that remediation. They try and see where the strong points and the weak points are, and they use the strong points to improve the weak points. So isn't that amazing? You're using a different pathway than the brain would have, but you are still trying to get to the same result. So for instance, here we've got a motor disorder. So that is gives rise to dyspraxia. Children who sometimes are not very well coordinated, tend to bump into things, or it could be more finely tuned problems. We were talking about learning to tie your laces this morning. That is something that we can offer in therapy to help with trying to improve that dyspraxia, because those fine-tuned things are quite useful. For instance, writing as well. It could be something that affects writing. Now, the kind of therapy we would use here is motor therapy, mainly, to try and improve that motor function. But another example here, you might have a speech disorder. Now, this is a bit more difficult to identify, and it's tied in with a general lower cognitive function level. Why? Because a lot of the tests that we run use language. We try and get the person to remember the names of objects and then to recite them. If they have problems speaking, then it will be difficult to assess their memory in this way, won't it? So unfortunately, speech problems or language problems are badly diagnosed, and people will tend to think that they have intellectual deficiency. However, it's just the actual speech part that has a problem. And as we heard from Angela Morgan, language is a very difficult thing for DDX3X. So often that means we tend to downplay the intelligence of people affected by this disorder because we don't have the right kinds of tests. And there are other kinds of tests as well. We've got the Wechsler scale to measure intelligence, and we've got non-verbal scales as well, where we try and assess it without using language. It's not so intuitive, it's not so well known as all of the other assessments that we make in neuropsychology. Now, learning, improving speech goes through a speech therapist, of course, and it's very hard to find somebody, a professional who has slots available. But there may be various different fields that are affected, language maybe, and your motor skills, and therefore you would have to use 2 therapists. And that's what you're seeing with your kids. Sometimes you know that they have several problems, and so they have therapy sessions throughout the week, and that's why they're so busy, because you have to try and boost all of the different skills. And then, of course, again, this is the star, but it's a smaller star, and that's what we call intellectual disability. So you have capacities, but they are just lower in all domains, in all fields. That's more difficult to deal with because you need to try and draw on the different strengths to improve the system. And it's very difficult, it has to be said, to deal with these patients and to improve them. They don't benefit from any specific therapy. You just need to have different approaches, improve language, improve the motor skills, but it's very difficult to try and get that star to enlarge. But now I want to focus on social cognition. Some patients were identified as having autistic traits with the DDX3X syndrome. And autism is, when you have a higher intellectual level than what would be expected. So here, yes, there is intellectual disability, but there's also other kinds of disabilities. When we're dealing with autism, everything is working except for social cognition. So that is the bit that has the disorder. And that's why sometimes we use the word autism a little bit too easily. I mean, yes, it means that you can get funding sometimes or get on a medical pathway that will then help you. That's all well and good. But actually, autism is about social cognition, where it's the level of that is lower than what you would expect for a generally functioning adult or human. And we have to do social skills training to remedy this. So there are 2 stages. We have to, first of all, make sure that the patient understands their emotions and other people's emotions. That's the basic thing, because if they don't, then you can't work on that relationship. Sorry, but then we have to use techniques to try and help them enter into a relationship with someone, identify whether that relationship is good or bad, etc. And that is the main problem, especially during teenage years. Now, what are autism spectrum disorders? Well, the definitions have completely changed. So it seems today that there are a lot more people being diagnosed as autistic as before. It's simply because the criteria have changed. But basically, you need disorders in communication and social interaction. That's what's at the top of the slide. And also in the restricted and repetitive characteristics of behavior and interest. People who are kind of focus on one thing, become obsessed, or impacted by a noise, one specific noise, for instance, the subway or something. And you've also got a hypersensitivity or hyposensitivities. You might be very sensitive to the light, to noise, or not at all. And that's difficult to notice, because if you put somebody in a very noisy atmosphere, it might be so problematic that it might engender disorders that are sensory disorders. And that's very important when you're assessing these patients to, of course, do a neuro and psychological assessment, but also a sensory profile, because what we're looking for is to see how they react to their environment so that we can then adapt the environment.
I'd
like to draw your attention to the fact that although we're talking about DDX3X, there are boys affected, but it's mostly girls who are affected by the syndrome. And girls are special because they can actually hide a camouflage. We call it camouflage in both French and English. It means that it's difficult to spot girls who have autistic-like disorders. Usually girls tend to blend into the environment and they can hide the symptoms. Boys are not quite so good at doing it. So girls can actually hide it and cheat, and this kind of autism-like disorder can be misdiagnosed. And, like the lady who said earlier, the doctor said to her, your daughter cannot be autistic because she has good eye contact. Well, that's exactly what I mean. sometimes it is acceptable to look people in the eyes, and therefore she has learned it. It wasn't automatic. She has learned that when she talks to people, she has to make eye contact, except that if you look more closely, probably she doesn't, keep her gaze focused during the whole conversation. But there are people who don't know about this, and therefore there can be misdiagnosed cases. And all the people you meet will be trained in the old school autistic patients do not talk, they swing, they bite their own fingers. I mean, they've actually been trained with a single side of the autism spectrum, but it's a wide spectrum. There are various kinds of manifestations. There are people who actually teach in university and yet they have autistic issues. So that's why it's very important that we see the evolution and understand why we still may go wrong in the diagnosis. Earlier, we talked about hyperactivity. Well, there will be a presentation later, but it's mostly about attention functions. And when we talk about hyperactivity, or it's the ADHD in English, it's attention deficit hyperactivity disorder. Sometimes people simply suffer from an attention deficit. They're not hyperactive. They don't jiggle on their chair. They don't jump around the place. No. They simply have an attention disorder. And if that is not recognized and monitored, it may lead to a number of other problems, because attention is absolutely essential if you want to learn something. Very often when we miss the attention deficit, we don't help the patient make progress. And that is something that will be managed by with pharmacological treatments. I'm not in favor of pharmacological treatments for the sake of it, but sometimes we need them. And there are psychostimulating drugs that work really well. And if they're well administered, there will be no major adverse events to fear. So sometimes you have to bear in mind that this dimension can be addressed. Now, are you familiar with a famous person who suffered from attention deficit without hyperactivity disorders? I'm sure you know who I'm referring to. A clue. Somebody who also suffers from hyperphagia. Somebody raised their hand? No. Okay. Winnie the Pooh. If you look at the cartoons, you will see that Winnie the Pooh can be distracted really easily. I watched the cartoon yesterday, and Winnie the Pooh was preparing Christmas, and his friend Piglet helped him, and he wanted to hide the present, and so he went around the house to find a place to hide the present and hid it in an empty honey jar. And there was a full honey jar next to it, so he ate from the full honey jar, and he forgot that his friend was there, so he continued eating the honey from the honey jar. He's not hyperactive, but he very often can be distracted, goes to a different room, doesn't remember what he came to that room for. And it can be normal, but sometimes it reaches a stage where it can be really disruptive in everyday life. Now, this Winnie the Pooh story is really interesting, because all the animals in the 100-acre woods suffer from psychiatric disorders. I mean, I didn't make it up. It's been actually published in the Canadian Psychiatric Journal, a scientific publication recognized and complying with the scientific standards, and someone invented a test. I mean, I don't take this for a real diagnostic test, but it's rather interesting. You can try it online. I did not want you to see my profile, so I just answered at random. But Winnie the Pooh has an attention deficit disorder. Piglet suffers from anxiety. Tigger is hyperactive. He jumps all over the place. Rabbit, I can't remember the name, is compulsive obsession disorders. He likes to have everything tidy. You know, there are children who want everything to be really tidy, and you place every object in a very determined place, and if you move them around, they'll be upset. The child, Roo, the kangaroo, is still in his mother's womb and is next to autism, but the worst one is Ior, because he's depressed. The donkey is always with his ears hanging low, looking forlorn, and finally the child. I mean, it's not perfect. The child suffers from schizophrenia. It's not perfect. schizophrenia might be a bit exaggerated, but all the other features can be observed in AnDDI-Rares children. And all these people in the 100-acre wood, in spite of their disorders, live in perfect harmony. The 100-acre wood is perfectly inclusive. Everybody lives in harmony. They're all suffering from some kind of disorder, but they live together. It's a good example of tolerance. Psychiatric comorbidities. And this is also true for the DDX3X syndrome, anxiety. There are different kinds of anxiety features, social anxiety, generalized anxiety. Obviously, social anxiety can disrupt interaction. Separation anxiety, that's something you observe. You take a child to school and they will roll on the floor crying and they don't want to be separated from their parents. There is obsessive compulsive disorder. Children who will simply count letters or figures. There is phobia. Children can be afraid of dogs or horses. Every time they see a dog in the street, they'll simply roll on the pavement. It raises questions for their monitoring and management. And anxiety is very close to depression. It uses the same biological pathways. When depression is present, there are also anxiety phenomena observed. And depression is defined quite simply by sadness and/or loss of the ability to feel pleasure. Some people can be depressed, but not necessarily feel sad. They like to go out and see friends. They no longer want to go out and see friends, talk to friends, but they're not necessarily sad. But that could be a sign of depression, not wanting to go out anymore. There are other features, such as changes in sleep or appetite habits, one way or another, actually. Appetite could increase and sleep could decrease, or the other way around. People are also tired, they are slow. And again, the question is that depression, or can it be part of the natural history of a genetic disorder? People who suffer from the syndrome may be more tired than the general population, but when that fatigue becomes intense, then you have to start asking questions. Finally, there's one thing that is often disregarded: irritability. Some patients are extremely irritable, very tense, very aggressive due to depression. There are paracetamol tests with patients. If someone has trouble expressing the symptoms but has pain, aches in the belly or elsewhere, they can become very irritable with the first person they come across. So one test in psychosocial centers consists in giving the patient paracetamol. And if that relieves the pain, then you can see what's the real problem is. And somebody who's depressed, has psychiatric disorders, cannot express emotions, may become agitated simply because of this psychic suffering that cannot be expressed properly. And that causes anxiety. And finally, that also leads to attention disorders, because people are focused on their thoughts and their sadness, and they don't focus on other people and everything else. Treatment, psychotherapy for light to moderate forms, except that psychotherapy with people who have trouble speaking may be a bit tricky. So we can also resort to pharmacological treatments. They do scare us, but sometimes they're good. Well, avoid benzodiazepines. If you go to your GP and say, I am depressed, they will put you on benzodiazepines, but that is not the right strategy. Because yes, benzodiazepines will relieve anxiety, but then the patient will become dependent on benzodiazepines, and it will be necessary to de-escalate the doses progressively. And sometimes it will make people even more nervous. So stay away from benzodiazepines when possible. But there are antidepressant drugs. And even though the patient may not suffer from depression as such, the antidepressant drugs can be extremely useful. We used it on DDX3X patients with very good results and no adverse events. For instance, sertraline can be used in young children, and it does decrease anxiety, decrease the stress level, and does not induce any adverse events, or no notable adverse events. And if they do appear, then we can discontinue the treatment anyway. Very often we grope in the dark and we don't know exactly what to do. I mean, let's call it that way. We're lost. And people try new treatments and then they have to turn back. But, you know, if you turn back, okay, fine, there are no consequences anywhere on the long term. Now, something about transition from childhood to adulthood, a very important time, which may actually disrupt the patient's management. Because when you move from childhood to adulthood, adults are not managed exactly the same way. Pediatricians look after children, but there are no doctors, adult doctors. And so the patient will have to see a neurologist, a psychiatrist, psychotherapists. There will be many different people taking care of the same person. You know, transition is always important. Transition is the time when anxiety and depression usually appear around the ages between 15 and 25. When you let go of the child's hand to allow the child to walk into adulthood, many abnormalities may appear, psychiatric disorders may appear at that time. It's also a time when people are vulnerable, socially speaking, because they meet other people the same age. Maybe they may love someone else, they may have sexual impulses, and you know, you have to look at how to make friends and social media. How do you protect them from the social media? And there's also the economic vulnerability. Until then, you depended on your parents, but then when you become an adult, you will receive subsidies from the government, from social services, but then you will start thinking about maybe work in a special institution where the parents will let go of you and will allow you to become integrated in a new group of people with special educators caring for you. So it's a very vulnerable period. There's medical vulnerability, there's social vulnerability, and there's economic vulnerability. And that happens all at the same time. I'll give you two examples. Two programs we have developed in Paris. Thanks to Charlotte Dansette and Evanderia Valadier, but there are other colleagues also helping. And there are neuropsychologists, psychologists being trained with these two programs. The first one is a program to support patients and allow them to acquire greater autonomy. We explain to them, okay, you have a disease, this is the disease, these are the symptoms. And then from then on, we have to set a target to move into adulthood. And so the patient's target will be, okay, now I have to be able to take my medication on my own without my parents to remind me. Because once I move out from my parents' house, then I'll have to be able to take my medication alone. So you try and help the patients self-determine. And the latest programs is the PEERS program. It's you can find it in the States. It's actually coming from California. The idea is to help the patient develop social skills so that he or she may become integrated in a group with people of the same age. Children between teenagers between the ages of 13 and 18, they can make friends. They discover what it means to have a friend, a good friend, and not a bad one. And this also is based on the fact that they suffer from a rare genetic condition. You have to say the word or not say the word. You know, yeah, they have to learn whether to tell people they suffer from a rare genetic condition. And sometimes we say you shouldn't talk about that. But now, if they want to marry and have children, they have to tell the person they want to marry that they suffer from a rare genetic conditions. These are the skills that we need to help them develop. And therefore, we reinforce the ring in the chain to avoid the chain breaking. And the family, we also have to help the family, help the parents, especially you following the meeting on Zoom. Take care of yourselves. There are people who took an airplane to come to this conference. In the airplane, they say in case of the cabin becoming depressurized, you need to take the air mask and put it on your face. But you should put your mask on first before helping other people put on their mask. But that's exactly the same thing. We have to help the parents so that the parents can help their children. We're not talking about running a 100-meter race. It's a marathon. Parents have to be there throughout their children's life. And so they have to take care of themselves. They have to also take it in turns. Maybe one parent will take a rest while the other parent is caring for the child, or maybe the grandparents can also help and give you some space, or educators and specialists can also help you take a moment for yourself. No one, and don't feel guilty. It's very difficult for a parent to be the parent of a child suffering from this kind of disease. You feel guilty if it's an ex novo mutation. It's not your fault. It just happens. It's not your fault. You shouldn't feel guilty. And finally, there is one last message. We have set up a very special interviews during which the parents will learn to look after themselves to be able to look after their children. This is a map of France. I don't have the globe, but I have France. And if people contact us, we will find correspondence across the territory because we have many different people here. So this is the map of France with the reference and specialized centers. There are several across the French territory. So if you don't know the addresses, send us an email. You have the email address at the bottom of the slide. You can we can either organize online meetings and we can also give you the address of somebody in your neighborhood that will help you. But again, the message is take care of yourself so that you can take care of your children. Don't be afraid of psychiatric specialists. It's better to see them early for no reason rather than waiting until it's too late. Well, thank you very much, Boris Chaumette. It was very, very.
Interested, just as our attention was caught up during Boris Chaumette's presentation. I will ask you to put on your headsets because the next presenter will be online. We're going to look at the lower part of the star that Boris Chaumette was mentioning, as we are going to have a look at ADHD with a professor from the University of Montpellier. Hello, Diane Purper-Ouakil. Yes, hello. Sorry not to be with you in person, but I'll do my best from here in Montpellier, in the south of France. And where the weather is nice now.
On vous avait devant vous, si je puis dire, dans cet auditorium du Sainte-Anne.
You have here more or less 150 people wearing a headset and listening to you. Okay, thank you, says Mrs. Purper-Ouakil. And there's a translation into English and Spanish. A majority of French people here in the room. You can switch to the right channel. Diane, is it okay for you? Yes. We can hear you in French. So there's translation into English. Can you hear? Yes? Sorry, Diane. We have to make sure everybody hears. So it's 2:25. Can you speak for about 20 minutes plus 5 minutes for questions? Is that okay? Well, thank you very much. Thank you. So we're going to go into details. Boris Chaumette has given you quite a lot of elements about attention disorders. So we're going to speak rather quickly on the main symptoms. It can be attention disorder, being impulsive or hyperactivity to a variable degree. Sometimes you have mainly attention or a mixed presentation. They're not just children that move a lot, but children that where this has a negative impact on the school environment, the family, or socially. So we have to try and see what's happening for them. So apart from these main symptoms, we have noticed that the disorders are really in the field of a self-regulation, really, about motricity or attention or emotional expression, emotional reaction or sleep or food. So we realize that ADHD is more and more an issue of self-regulation. So let's talk about prevalence. It's a frequent disorder. The latest studies covered 204 countries for children and teenagers. And the prevalence was 5.41%. For adults, the figure is a bit lower, between 2.5% and 3%, because a number of people no longer correspond to the criteria. Overall, contrary to what the media tend to say, the prevalence is rather stable over time. These figures of prevalence do not vary really a lot. What is certain, as you can see here on this graph, girls in pink and boys in blue, rather conventional. So the prevalence is more important, much more important in boys, but the sex ratio tends to balance over as age grows. Meaning that a bit more girls are being diagnosed, and this probably for several reasons, and I haven't got time to go into details. We can discuss it in the chat later on. There's one dimension that is often associated, emotional issues. These youngsters are irritable, tend to get angry, they can, their mood changes a lot, and they react very strongly to the environmental stimulations. And once they express their emotion, they have trouble toning down and controlling their expression. And sometimes this may be more of a problem than the motor instability. There are other disorders that are frequently associated. You should remember that when you diagnose a neurodevelopmental disorder, you should look for others, because one tends to have an association of different disorders. So when you have an ADHD, you have to look for specific learning disorders, motor coordination, autistic spectrum disorders. So several disorders in neurodevelopment can be associated, and then you have more psychiatric ones like anxiety, depression, or bipolar disorders. This is something that is more prevalent in adults and adolescents than in children. Defiance, abuse of substances, tics, sleeping disorders, and other health issues. We tend to forget to look for other long-term diseases like obesity or high blood pressure or others that can appear. So when you talk about neurodevelopmental disorders, we tend to look at the evolution over the long term. They are maybe age dependent, but also context dependent. Because some parents say, I don't think my child has an ADHD because when playing on a video game, the behavior is perfectly normal. Well, this is perfectly normal because you have immediate reinforcement through the game, the play, or the visual simulations that are extremely attractive for these youngsters. And so you have a reduction of symptoms in this type of context, immediate reinforcement or dual situation. Sometimes if you do a neuropsychological test looking for attention disorders, the test is normal, but even then you are within the criteria of the diagnosis, because the attention disorders will be very strong in everyday life, like in the morning, evening, or certain school situation, where especially when they're repetitive or a bit fastidious or boring, or when you have a lot of competition. And also when the child is tired. And you must think that there are differences between the different members of the family. Mothers indicate more symptoms usually than fathers. This is probably due to the frequency of contact and that the daily tasks really are more incumbent still on mothers than fathers. So the evolution of symptoms with age go towards spontaneous reduction of motor hyperactivity. Spontaneously, this will improve with age, with or without treatment. Obviously, much better with a treatment. You have also a regression of motor hyperactivity. Aggressivity also tends to be reduced, not so much that they're less aggressive, but when they're little, they are rather abrupt in their gestures and they have less control. And with this lesser control, for example, during recess, they might hurt or lead to a problem in socialization. The most visible things with age are distraction or lack of attention, organization, planning, feeling of boredom, looking for sensations, especially in adolescents and adults.
Et l'impatience et les tensions internes, et on le
You
voit ça
can
chez les
see
adultes.
that also impatience and inattention. We can see that these people need to move, to get out of their meetings, to walk. These are phenomena that could be related to these impatience more than motor instability. So very quickly, the neuropsychological profiles linked with ADHD, they have trouble planning and organizing. This is executive deficit or disorder. You have an inhibition disorder. This is the same as what I showed you about the self-regulation, meaning they lack barriers. You react to your environment, but you tend to react too fast and too strongly, and especially not to take into account the context in order to adapt your response to your environment. And this is something that is very often lacking in these people, and a lack of tolerance to the delayed reward. Meaning that if you promise a child with an ADHD reward in the next 3 months, it will never work. So as I said, it's non-specific, context-dependent, and not always related to the clinical symptoms themselves, which is why you don't give a diagnosis with the tests. You carry out a neuropsychological test to get an idea of the how they operate and to know the strengths and weaknesses, but you cannot give a clinical diagnosis with this. You have to take into account the symptoms and a wider analysis for a diagnosis. Does it persist at adulthood? Yes, but probably in an attenuated fashion. Most of the time, it's difficult to have a diagnosis that corresponds to all the criteria. Obviously, with the classification adjusts over time, but as you can see here, people mostly retain residual symptoms, or that may be a hindrance. Here, this slide is a bit heavy, but what I wanted to show you is that the raw causes of ADHD are multiple factors, and the genetic factors and environmental ones can vary in proportion. Some will have more genetic elements, others more environmental ones, some that have been exposed to some elements during pregnancy. And so you have the neurobiological and neuropsychological phenotypes. and then the symptoms are being looked at, and there's a lot of research being carried out because it's a multiple factor disorder. So to come back more precisely to the genetic mechanism, which is interesting, you should remember that it is a disorder that is strongly influenced by genetic factors. And if you look at the proportion in a population, the respective proportion of environmental and genetic factors, it's over 70% for genetic factors. Some may be common variants, the variants that everybody has. When they are in a certain situation, i.e., when several of these variants, which in isolation do not lead to any risk, when they get together, they may have an impact on the risk of developing some symptoms. This represents about 40% of heritability, and then 30% also, for example, are ADHD forms that are more influenced by rarer or low frequency copy numbers. And the DDX3X is one of them because it's part of the pathogen variants that can be either de novo or transmitted. And and then you have the rare chromosomal anomalies. So the more the genetic anomalies are important, the more symptoms you have apart from the typical ADHD. So you can have other disorders in neurodevelopment or other intellectual disorders. This is what I wanted to tell you. This is a multi-factor issue, and therefore several networks are at stake. The thalamus, the frontal part of the brain, you have a lot of homogeneity, and a lot of things are shown by the imaging now. We see anomalies in the connections. For example, the default networks, which are associated to the resting state of the brain, is going to become active when you're carrying out a task, which probably explains part of the ruptures in attention or
c'est important de parler d'adaptation de l'environnement et on va rentrer dans les traitements qu'on appelle non médicamenteux ou psychosociaux.
So now let's talk about the treatment that we can provide. And of course, for young people, we've got the intervention of parents, we've got psychoeducation to explain what's wrong with them. We've got parenting skills, training programs, what we call PMT, and then we've also got improvements to the school environment, attentional mobilization, adaptive framework, contingency management, also providing sometimes personal support or even computer assistance. And that can be provided in the classroom, and that can really help. Now, the basics of parent management training programs. There are different programs. I'll show you a couple, but overall, they're using the same basis. Basically, you use the lever of the parental response to modify the child's behavior. And parents really have to pay a lot of attention to the positive behavior coming from their child, because that will boost and stabilize the child's progress. And of course, positive attention is important, and reinforcing, helping parents pay attention to the positive behavior, relying on positive reinforcement and non-reinforcement of undesirable behavior, because that can have a big impact. So if you pay a lot of attention to undesirable behavior, then that will boost that kind of behavior. It seems quite logical. And we try and reinforce parents' progress as well and boost their confidence. And we certainly help that they can come away from these programs with various strategies and just a feeling of empowerment in their strategy and feeling as a parent. I won't go through all of this. This can the information can be found on the slides, but there's a lot of information online as well. Now, just quickly on non-drug treatments. I know I have to speed up a little bit to have time for questions, but non-drug treatments is mainly with psychotherapy, so mainly cognitive or behavioral therapy to allow the child to learn strategies and planification to solve problems. But you can also work on things that aren't necessarily targeting the symptoms or self-assertiveness or socializations. And you can also work on remedies, for instance, to do with the cognitive or metacognitive side of things, or neurofeedback, which is also useful. I won't go into too much detail on that. There's a lot of studies out there, and I can certainly provide you with the links for that. Now, educational facilities. This is something that's given by the French educational authorities. It tells you what the different possibilities are. It goes from the simplest plans, personalized help plans, which needs no recognition from the medical authorities. That's automatically set up in schools. Then you've got a more specialized and tailor-made strategy. Again, it's not too difficult to access this. You can just agree with the teachers, and usually the school doctor can validate that. Here, this is a little bit more intense. So this is a file that you have to submit to the health authorities. And then the PAI, that can be quite useful if there's no learning difficulties, but the child has to take medication, or if there are amendments that don't come under one of these four strategies. I'd now like to just talk about effectiveness data and the various CBT approaches. As for the parent management training programs, we've been able to show now that they don't have direct efficiency on hyperactivity or impulsivity, but they do reduce the risk of oppositional behavior, and they protect and they reduce the negative strategies, and they reduce that side of things. And this is something that's offered systematically now. All of the international recommendations seem to be pinpointing them and saying that they're useful because they have an overall impact on the care. And they also give parents empowerment. Now, child CBT. Studies have showed that there isn't very much a high effectiveness in the cardinal symptoms of ADHD. There's possible interest in programs combining social skills and problem solving, but it's mainly used to help with other therapies or strategies. And we run these kinds of programs where we try and tie things in with the school teachers to try and set up strategies to help the child remain in school, reduce their suffering and problems with their self-confidence. There are various different classroom presentations based on contingency management, probable effectiveness, but heterogeneous data mean that we can't really tell whether it's efficient. The CBT for adults has a better score, especially when you compare it with other kinds of treatments. The efficacy here, I would say, is average, but warning, of course, this data is for adults who were volunteers and they were really motivated to try and take part in these studies. So that's not necessarily the case for everyone. Now, for cognitive approaches, I'll be quick because it's not in favor of neurofeedback or cognitive training because programs were assessed blindly. That is to say that when you see the patient that knows what kind of treatment they are receiving, there are effects, but they are non-significant effects and they can't be applied to the different contexts. So psychostimulants, Boris mentioned these earlier. Methylphenidate, that's the only that's sold in France. But here, this is an international conference, and I'm sure you also have psychostimulants that you use related to amphetamine. It's not sold in France, some of them, but they protect from the negative sides of taking amphetamines, the flashes and the kind of addiction that you might have. Methylphenidate is totally secure. There's no antihistamine effects. Prescription is fairly straightforward for ADHD. So I've set some different psychostimulants out here. There are different kinds of drugs, and if one doesn't work, you can try another. In second-line treatment, sometimes we try and use Strattera or catapressine. These drugs or medication are available, but you need to, they're not officially accredited to the market, so you have to get specialist approval. Now, there are other health issues in ADHD, training, organization of care. There's a lot to do with social representations. These children are often not properly cared for. They're often from poorer families, and also personalized care is a big issue as well. Of course, there are strategies to hide all of the symptoms, but we need to try and help this move along. Thank you, and I'm available for questions.
Merci beaucoup, Professeur Purper-Ouakil.
Thank you. Okay, as you know, children affected by ADH have a lot of different emotions, but a lot of stress and a lot of anxiety. So our next speaker has taken time to describe all of this in a study called the Bingo study. It's not just about the syndrome we're dealing with. She's a PhD student from Cambridge University. This is Jessica Martin. Over to you.
Hello, thank you for having me today. So I'm going to start my presentation by zooming out from DDX3X. So we know that rare genetic neurodevelopmental disorders are individually rare, so like DDX3X, but collectively they're very common. So neurodevelopmental disorders caused by spontaneous mutations, so de novo mutations account for 1 in 214 to 148 births, and there are more than 1,000 genes that have been associated with neurodevelopmental disorders. We also know that mental health symptoms are highly prevalent in children and adolescents with rare genetic neurodevelopmental disorders. A recent study found that approximately 51% of children with rare genetic conditions will experience clinically significant mental health symptoms, compared to about 12% of children that don't have a rare genetic condition. And that of particular concern are the high prevalences of anxiety and also oppositional defiant disorder, which is a behavioral disorder characterized by defiant and disobedient behaviors. So where does the Bingo project fit into this? Is it not what? Oh, sorry, I need to speak closer. Okay. So where does the Bingo study fit into this? So the Bingo project aims to explore the intersection of mental health difficulties and rare genetic conditions. in particular, why are some people with rare genetic neurodevelopmental disorders vulnerable to developing mental health difficulties, but also why mental health difficulties are not universal. So just because you have a rare genetic neurodevelopmental disorder doesn't mean that you'll go on to experience a mental health difficulty. We're also interested in understanding what the characteristics, so what the different symptoms of mental health difficulties might be, including how variable they are and why they might emerge. So finally, I'll start talking about DDX3X, which I know is what everyone here is interested in. So mutations in DDX3X have been associated with neurodevelopmental conditions, including intellectual disability and autism, but also mental health symptoms, including anxiety and self-injury. But there are a few limitations with our current existing evidence and the literature that we've built up through research. So lots of this research tends to rely on clinical reports and formal diagnosis. And when we do use measures that capture a range of behaviours, we tend to focus on whether that child meets a clinical cutoff or not. And what this means is that we struggle to determine variability in symptoms. So children might display a range of different behaviours, but if we're only focusing on those that have lots of those behaviours, then maybe we're missing those that maybe show a few symptoms. So we're not able to explore variation in severity or the different symptom profiles. And also, when we do use these measures, they tend to be designed for populations that didn't have intellectual stability. So typically developing children that then go on to maybe develop anxiety. And it might be the case that the symptoms of anxiety present differently in girls with DDX3X or young children with DDX3X. So we know in autism that quite often anxious traits tend to be related to the autism symptoms. So they might be related to, for example, social difficulties might not be caused through a fear of the social interaction itself, but rather from the fact that it violates patterns or rules, which autistic children tend to favour. And also that a lot of this research doesn't use a comparison sample. And what this means is that we don't know whether these patterns of behaviours or difficulties are unique or specific to DDX3X, or whether they are even beyond what we might expect for the level of developmental or intellectual delay. So in our group, we tried to address some of these limitations by talking to parents of 46 girls, and 23 of those had a daughter with a DDX3X mutation, and 23 had a daughter with mutation in another gene. And we didn't find any differences in the age range or in the level of intellectual stability. So we asked parents to report on parent-reported measures of adaptive behaviour, so that's like daily life skills, social communication abilities, motor abilities, and also we used a measure of emotion and behaviour that's been specifically designed for people that have intellectual disability or developmental delay, and a measure of autism characteristics. And what we found was that there was no difference in adaptive ability between girls that have a mutation in DDX3X versus girls that have a mutation in another gene. And we found also no difference in the levels of autism characteristics. But what we did find is that girls with DDX3X mutations had higher levels of anxiety and higher levels of self-injury. So these may be negative behaviours that are directed towards the self, like hand biting or hair pulling or skin scratching. We also found that there might be unique relationships between these different traits. So there might be a specific pattern that we see that might be different to what we see in girls that have mutations in different genes. Okay, so to summarize so far, we know that girls with DDX3X associated neurodevelopmental disorder might experience high rates of anxiety and self-injurious behaviors, and this might be above and beyond girls that have mutations in different genes, and that there might be unique associations between neurodevelopmental and mental health symptoms in girls with DDX3X. But so far, evidence is kind of limited by the measures that we use and by our study design, so not comparing girls with, and young boys as well, which I know Amelia will talk about in a minute, comparing them together. So in my PhD, I wanted to kind of delve into these characteristics in more detail. So I'm trying to explore the characteristics of anxiety in young children, adolescents with DDX associated neurodevelopmental disorder. And to do this, I'm using a bottom-up interview with parents and caregivers, and I'm taking a clinical psychology approach. So in clinical psychology, part of our bread and butter, or in wine, you might say your cheese and in wine. In France, you might say your cheese and your wine, is to think about the different factors that might be contributing to whether someone has a difficulty or not. So I'm using what we call a 5P formulation approach, and this involves thinking about someone's presenting difficulty. What is the current issue they're having? What might be triggering that difficulty? What are the behaviors, the emotions, the thoughts that they're feeling? And how frequent, severe, and what is the impact of this difficulty both on themselves and their families? We also think about the factors that might have contributed to the emergence of this difficulty. So Boris mentioned earlier that psychiatric conditions co-occur, so they frequently occur together. So we ask about a previous or current experience of depression or any family or developmental history. We also look to see whether there are any events that might have immediately preceded the onset of the anxiety. So sometimes anxiety can be triggered by specific events. For example, if your child was very ill and they had a long period in hospital that was traumatic, or maybe they've had a transition to a new school and having difficulty establishing new relationships or friendships. We also look at factors which might maintain the anxiety. So something we sometimes do when we're anxious is we avoid the thing that makes us anxious. But by avoiding the thing that makes us anxious, we never learn that there's a different outcome, that actually that could be a positive experience, or that it's a safe environment. Finally, we look at protective factors. These are factors that contribute to resilience and strength, and are things that reduce the impact that the difficulty might be having on our daily lives. So, so far in my PhD, I've interviewed 13 parents and caregivers of girls with DDX3X mutations. And just to note that this was not just mothers, we also had a mother, father, and a mother and her partner that we interviewed. And we found that 9 of these caregivers reported that their daughter experienced some level of anxiety or some kind of anxiety. And just to note that we didn't find any differences in the age range of these two groups, so the group with parent-reported anxiety versus the group that didn't have any anxiety, and no difference in their level of developmental delay either. So what about the anxiety itself? So we found that parents reported that the anxiety can emerge at any stage through life. So some parents reported that their child had always been quite anxious from when they were a baby. Most parents reported that it arose in middle child, but also into as a teenager. And that all of the types of anxiety parents reported was triggered. So this means there's a specific event or object or situation that they dislike, rather than there being a constant level of anxiety, which we might call generalized anxiety. And that also all of the parents reported that their child's anxiety emerged quite gradually over time. So it wasn't one day their child woke up and they were anxious and they weren't the day before. So did parents report that there were any factors that might have contributed to the emergence of anxiety? So in particular, we asked parents about whether their child had any previous or current experiences of depression, and we found that no parents reported any depressive symptoms or behaviors related to depression. And what about any events that might have occurred immediately before the onset of anxiety? We only found that one parent reported that there might have been an event that was linked to their child developing anxiety, which in this case was transitioning to a new school and having difficulty establishing new friendships or leaving old friendships behind. So that was factors that might contribute or precede the onset of the anxiety. What about factors that are triggering that anxiety? So the current difficulty or issue that's causing someone to become anxious. So parents were allowed to report on multiple different factors that might have caused their daughter, or patterns that they saw like, for example, or when we go to the supermarket, she becomes really anxious, or when we go to the park and she sees a dog, she becomes really anxious. So parents reported on a wide number, and the most common were routine changes, new situations, and sensory sensitivity. So this was something that Effie mentioned earlier that her daughter experienced as well. And just to note that there were some parents that reported specific phobias, one of dogs and one of babies and small children. As you can see from the graph, that actually there are a number of different factors that might have triggered anxiety, including kind of a lack of sleep or social performance and performance situations. So what behaviors do girls show when they're anxious? We asked parents to describe what their daughter looks like when she's anxious. Does she show any changes in the way she communicates, in her facial expressions, in her behavior and her movement? and also in physiological symptoms. So things like having a faster beating heart or breathing more heavily or going very red and flushed. So again, parents could report multiple different behaviors because we don't just show one thing when we're anxious, we show multiple different changes. And the most common changes we found were crying, repetitive speech, maintaining distance, muscle tension, and talking to others. And one thing to note is that we found that parents found it quite difficult to report physiological symptoms, so things like changes in heart rate, which kind of makes sense. It's sometimes difficult to know whether your own heart rate is changing when you're stressed, let alone thinking about whether there's changes in your child. And I forgot to mention earlier, but this same kind of framework has been used to look at anxiety and Williams syndrome, which is another genetic syndrome where individuals experience high levels of anxiety. And they also found that parents found it quite difficult to report physiological symptoms. Okay, so that was the behaviors. So let's start thinking about how frequent, severe, and the impact of the anxiety. We found that parents reported that anxiety was somewhat frequent in their girls, occurring most frequently at least once a week or once a day, and that the anxiety had a mild to moderate severity. And what this means is that the symptoms are noticeable to others. They might have some lasting physiological symptoms, but it's actually quite easily overcome, and it doesn't severe significantly with everyday functioning or relationships. And we found that actually a lot of parents felt that the anxiety didn't really impact their daughter in any way. Then most parents reported no impact or a mild impact, but actually parents are reporting that the anxiety was having quite a significant impact on them or their family's ability to kind of go about daily routines or family activities. So that was the impact and severity. So what about strategies? How are people coping and what are people doing? So perpetuating factors can be thought of as factors that might maintain the anxiety, but also how people manage the anxiety. So we found that parents used to both active and avoidant coping strategies. So this includes things like reassurance and giving comfort. Effie again mentioned earlier things like deep pressure, hugs, weighted blankets. They can provide comfort, but also things like distraction. So drawing, singing, eating, all the things that your daughters might enjoy, you can use to distract them from while they're feeling anxious. Then also doing things like avoiding triggers and events or removing them from situations that might cause them to become anxious. And how are people coping? So we asked parents to report how they were coping on a scale of 0 being absolutely no control to all the way to 10 being an extreme amount of control. And we found that parents reported that they had a reasonable amount of control, but it's important to note that there's quite a lot of variability here. Some parents were finding it very difficult to feel in control, whereas others really felt like they had their the child's anxiety down. Okay, so to summarize here, in our preliminary interview evidence from families suggests that anxiety tends to be a response to specific triggers in girls that have DDX3X, including routine changes, new situations, and sensory sensitivities, and that a wide range of anxious behaviors are displayed, including crying, repetitive speech, and maintaining distance from a trigger. And that anxiety is somewhat frequent and mild to moderate in severity, and parents use a variety of coping strategies and feel that they are reasonably in control. So that's what we've done so far. So what's next? So as I mentioned at the beginning, one of the main limitations of some of the research in this area is that we don't include a comparison sample. So we can't ask questions like, are these behaviors unique to girls and young people with DDX3X mutations? And are there maybe specific patterns in the way these symptoms or difficulties emerge? So I'm trying to do that in my PhD by comparing these characteristics in girls that have DDX3X mutations and girls that have mutations in other genes. And we're doing this by using parent report measures of anxiety, autism characteristics, challenging behaviors, including self-injury and aggression, and also communication differences. And sensory processing, we mentioned earlier that some girls might experience sensory sensitivity, so we think it's important to look at that too. We also want to explore possible pathways that might contribute to anxiety or might be a factor in why it might emerge. And we're looking again at sensory processing, communication. I think in Angela's talk, she talked about how movement and difficulty to kind of produce words might contribute to difficulties that girls have with language. So is it the case that actually, if you can't express how you're thinking or what you're feeling, that actually you might show anxious behaviors because you're trying to communicate that? I'm also interested in looking at self-regulation. And what I mean by self-regulation is how do you regulate or control your emotional reactions when maybe something upsets you or makes you very excited. And the way we're doing that is using a combination of games and looking at changes in heart rate and physical activity. So this is me wearing a small monitor that measures my heart rate and my physical movement. And this is my setup. So here we've got a table with lots of cameras and different toys. And some of the tasks we use, some of you might have seen on Instagram or Facebook, which is where parents might give their child a treat, like we use marshmallows, and we say, here's one marshmallow. I'm going to give you this marshmallow and you can eat it now. Or here's a second marshmallow. If you wait while I leave you, then you can have 2 marshmallows. So we're interested in the kinds of behaviors that children are showing when they're trying to stop touching the marshmallow. So the marshmallow is something they really want. What do they do when they can't have something they really want? Or conversely, we give them a toy and we take it away. What happens when they have something they really like taken away from them? So we're interested in looking at that ability to regulate your emotions, because potentially if you're worse at regulating those emotions, you might be more likely to find things that you might be more likely to go on to develop anxiety or have difficulties responding to things that you find difficult in your environment. So why might this matter? Why does this research matter? So we're hoping through this research we can identify behaviors and traits that might be indicators of anxiety. So as I mentioned earlier, if girls with DDX, we know that some of them might have difficulty with language, and if you can't communicate your thoughts and feelings, you might express your behaviors through your emotions through your behaviors. So by identifying what these behaviors are, we might be able to better inform future diagnosis and enable girls to get better intervention and support. This doesn't mean that you can't still get that support now. And also by looking at variability, we're raising awareness that neurodevelopmental and mental health characteristics aren't an inevitable consequence of having a DDX3X diagnosis. And some girls might go on to develop different patterns and different strengths and difficulties. And that's why we're looking at what factors might contribute to the emergence of these over time. Also, just to mention, finally, we're still actively recruiting. I'm halfway through my PhD, so if you have a daughter who's aged between 3 and 18 years old and has a DDX3X mutation, and I know there are clinicians and people that are working with broader charities that look at children that have different genetic conditions, we're also looking to recruit those children too, so we can understand differences and maybe unique patterns. And finally, just want to say thank you to the bingo team, my supervisor Kate Baker, and also my supervisor Sam, who's based at the University of East London. He provides the monitors that measure heart rate and physical activity, and to PIs Jane Waite and Rachel Royston, who have been really helpful in informing the research looking at anxiety. But finally, the biggest thank you goes to all of the families who've taken part in the bingo project, because this work wouldn't be possible without you.
Merci, Jessica Martin. Maybe you can get back.
Thank you, Jessica. Thank you. Maybe you can go back to the previous slide if people want to write down your email address. So if the English rugby players are as fast as you are, tomorrow at the Stade de France, they're going to eat the Argentinian team alive, and they will avenge the French team who lost the quarterfinals. So thank you very much to the 2 previous speakers.